Welcome, everybody. Thank you for signing up and joining me today to talk about the racial inequalities in maternity services. And just before we get started, a few housekeeping rules. If we could keep our mics off when we're not speaking, that would be really great. And just to let you all know that this conference is being recorded and it will be available on YouTube in the next coming days. Welcome, everyone, and happy International Day of the Midwife. Thank you all for taking the time to join me today and discuss the racial inequalities in maternity services. I hope everyone who attends today or watches the recording at a later date learns something and is able to practice in a more inclusive manner going forward. In the morning session, breakout groups will be happening so you can all have an open, honest conversation about some of the topics covered today. I would really like it if you would all try and interact with your fellow attendees if possible. There will be times for questions during the student panel with myself, Jordan and Renee at 4:15. So please make a note of any questions you may have throughout the day. Today's itinerary, we have a lot to cover. So we're doing a welcome talk now, and then at 10:45, LSBU Senior Midwifery Lecturer Sarah Esegbona-Adeigbe will be discussing how midwifery education can help reduce racial disparities in maternity services. There'll be a comfort break at 11:30, and at 11:45, I'll be discussing what bias is and why stereotyping is dangerous at 12:30. At 1 p.m, we'll break for lunch, and we'll be back at 2:15 to hear Mars Lord, also known as Abuela Doulas, to talk about the disparities in maternity services. At 3 p.m, I'll discuss how we can all try and dismantle bias, and then that's followed by another comfort break. At 3:30, Jade Sullivan will discuss her experiences of NHS maternity services, and then at 4:15, the student panel will commence with Jordan, Renee, and myself. My name's Amber. I'm a first-year midwifery student at London South Bank University. Before I became a student midwife, I was a dental nurse for 8 years in a mixture of NHS and private practices, specialising in oral surgery and prosthodontics. The reason I chose to study midwifery is because I have a passion for supporting women in vulnerable times, and I was very interested in the biology and physiology of childbirth. The aims of today are to try and understand the effects of bias and stereotyping when it is incorporated in the care we provide in maternity services, recognise that everyone has some form of bias and we all need to work to dismantle it, in which will lead to a better care in maternity services and in the wider community. If you feel uncomfortable, question it. Understand why you may feel that way, and challenge and educate yourself in the way that you think and your approach. For the disparities to end in maternity services, we all need to put in the work to create change. Black women are 5 times more likely to die in childbirth or up to 1 year after compared to their white counterparts. Mixed ethnicity women are 3 times more likely to die in childbirth or 1 year after compared to their white counterparts. And Asian women are 2 times more likely to die in childbirth or 1 year after compared to their white counterparts. Stillbirth rates for Black and Black British babies are over twice of those for white babies. Asian and Asian British babies are 60% more likely to die than white babies. Women living in deprived areas are 80% more likely to experience stillbirth or neonatal death. What could be the cause? Women of colour who die during childbirth or in the postnatal period are leaving behind children who have to grow up without their mums, and this can have a damaging effect on their mental and emotional well-being, and possibly lead to a lifelong trauma experience. And it can also have a detrimental effect on their husbands or partners and the extended family. Women of colour who suffer from trauma during childbirth and in the postnatal period don't die are at risk of suffering from post-traumatic stress disorder or postpartum post-traumatic stress disorder, which can last for a long time and have severe effects on them and their families, taking years for them to recover. Statistics suggesting rates of maternal deaths are higher in women of colour compared to their white counterparts raise one important subject: racism. Gemma McKenzie of the Ames charity has said, "People do not like to talk about racism. It is the elephant in the room. It can make people, especially white people, very uncomfortable. No one likes to think of themselves as a racist or acknowledge that they may be unconsciously benefiting from a racist system. It is easier to believe that racism is something overt and direct, name-calling or violence, than to believe it is something that can be structurally ingrained into an institution, a system, or a society. Racism has been ingrained into our healthcare system for hundreds of years, and despite us as a society making many advances, women of colour are still being penalised in maternity services because of the colour of their skin and different cultural backgrounds. We must create change and have a fairer system that caters to all without prejudice and discrimination. Preventing maternal deaths and birth trauma in Black, Asian, and mixed ethnicity women is essential, and we can all play a role in bringing down these disparities and provide better outcomes for women of colour. We should all strive to have better births for all." So how does hearing those statistics make some of you feel? You can unmute yourself and share any thoughts and feelings.
Hi, my name's Wura.
Hiya.
Hi, I'm a third year midwifery student, and I'm coming back. I'm in my final year. My dissertation, funny enough, is on change management and how to reduce rates of maternal death for Black women. So, as both a service user and a caregiver, as both a Black service user and a caregiver, it's frustrating because I remember in my university, I've been trying to bring it up for a while. But what you said earlier about racism is the elephant in the room, and a lot of white women in particular feel very uncomfortable having to discuss it. It makes it really frustrating for ethnic minorities to have a voice when your voice is constantly being lowered
Yeah.
to make others comfortable. And that's the thing, we're always uncomfortable.
Mm-hmm.
You know, Black women, we're always uncomfortable. Asian women, we're always uncomfortable to bring it up. But what I found, because I'm in the Midlands, is that as long as the majority, which is white women, are comfortable, then you don't bring anything up. And that's what a lot of them don't want to, they don't want their table shaken, as long as our
Yeah.
table is always shaken, if you get what I mean.
I totally understand what you mean, and I think that is very true across many different trusts in the UK. I think we all need to accept that it's not fair for anyone to be feeling uncomfortable, especially women of colour that we're
Mm.
looking after, and the staff as well, because I do know that staff are being penalised for their colour of their skin and maybe their cultural backgrounds also. So something really needs to change.
Absolutely, absolutely.
Does anyone else have any thoughts on the statistics, or have any experiences they'd like to share?
Amber, I will share. I am a newly appointed maternity NED champion, newly appointed maternity champion, non-executive director. And I don't have a medical background, and I came into this quite cold, really, not really being completely unaware of the statistics, and frankly, I'm embarrassed to say blind to this. And I look at this, and I mean, I guess where I stand is there is, at least we have the facts. Here are the facts. They're undeniable. They're stark. And we've got to wake up and smell the coffee and do something about it. And so I'm so grateful that you know, we've come together today to acknowledge it and to be determined to do something. You know, even in our small spheres of influence, I think if we can take that away, that would be success, really. You know, to commit to do something in our spheres of influence.
Absolutely, I agree. Thank you, Aruna. Do you have any thoughts of what we can do in our practices to help bring change?
Well, for me, I think the starting point is I've certainly committed to going to all the Maternity Voices partnership. To hear the voices, because if you don't hear the voices, you really don't know. You can make assumptions that it is, you know, continuity of care, or, you know, you can see the statistics and make assumptions. But I think hearing the voices, hearing the experiences firsthand, has got to be this, at least for me, coming at it cold, has got to be the starting point, and looking for that low-hanging fruit, really, that can make a difference. And you know, I'm hearing attitudes, but I need to see it, feel it, and hear it before I can pass judgment, to be honest.
Yes, of course. I agree. I think everyone needs to start listening to the clients about their experiences and how they feel, and listening to the staff as well. Thank you, Aruna. Does anyone else want to share how they feel about the statistics? This is really an open conversation, so we can all learn and try and make a change. So I'm really excited to hear what some of you have to say. So please don't be shy, just come forward and share what you think.
One thing I'm excited to learn about from today is how to bring about change, because when I read these statistics over and over again, I think, why is this happening and how can I bring up?
Oh, I think we lost you.
Sorry, I was muted. But being a service user, like being of that community myself, and sometimes seeing how we're treated, it just encourages me so much to be that voice and bring about that change. And like you said, that sometimes white people don't want to hear it, they shut the conversations down, but it's our job, being part of the group, is to be that voice for all the other women, and that's part of our role as a midwife as well. So I'm really interested to hear what the rest of the day brings.
Thank you, thank you. Yes, I agree. We all need to start elevating women of colour's voices. I know sometimes it's difficult, especially when you might have to do that with senior members of staff, but there's always a way to do it in a way that is professional. And if you speak to other colleagues and they can provide some sort of support for you to do that also. Would anyone else like to share how they feel about the statistics and what they think needs to be done?
I did put this in the chat box, but I'll just say it anyway. I basically just commented on the lack of priority that we have. I work in the NHS in an LMS up north, and I think that we need to change the way we're looking at this. It's still seen as quite separate from the mainstream work that we need to do, and then add on to, oh, well, we have to say we're doing something. So really what I'd like to see is that it's embedded into other key agendas in a much more comprehensive way. You know, we're looking at risk of death, and when we see other work that's being done, such as the Saving Babies' Lives work, where the risk is stillbirth, it's still a risk of death.
Mm-hmm.
Why is this stuff not prioritised as much when the risk is the same? We're trying to reduce people dying, and it's just not given the same priority. It's really, really frustrating.
Yeah, I totally get you. It's so frustrating. And someone has put in the chat box, institutional racism needs better acknowledgement and action. And I agree, it's not just a maternity services issue. It's not just an NHS issue. It's an issue that are in many institutions in the country. And that really needs to be tackled and acknowledged. And people need to stop denying the institutional racism when it's brought up. Anyone else?
Hi.
Yeah.
I'm Danny. I'm a student in Edinburgh.
What year are you in, Danny?
All of this is that I feel like I'm in my second year.
Okay.
Yeah. So my experience has been quite interesting in Edinburgh because there's pretty much zero representation of POC women or people in education and just in the work environment. And my response is kind of that I think it needs to be tackled from our universities, and we're just not really taught about institutional racism at all. It's just not a conversation. And I really feel like that needs to be a module, or it needs to be taught by people of color. I don't really know. I'm just in conversation with my uni at the moment, trying to think of ways to go forward. And I feel like as a student, it's you're really vulnerable, because you don't really know how much voice you can have or how much power you have. And I'm lucky that I have people at the uni that kind of support me in this. But I'm really curious to hear how other students are tackling this, and kind of what their needs are, and how we can move forward together, in an educational sense basis.
Okay, thank you, Danny, for sharing. Yeah, I totally agree. It needs to start with universities, and it can be quite daunting going to your course lead or central management team of your course to bring up these ideas. But trust me, they will listen. If you use your voice and you articulate yourself properly and you get your point across well, they will listen. So if you need help in doing that, please do get in contact, because I'm more than willing to help you.
Yeah, that would be great. Thank you.
You're welcome, Danny. Would anyone else like to share?
I think just to add to that, my name's Laura. I'm a first year student in London. I've noticed that within the actual teaching on a practical level, obviously I know it's difficult on Zoom and everything's on PowerPoints at the moment, but I've noticed that the pictures of, oh, this is what this rash looks like, this is what jaundice looks like, the babies are always white.
Yes.
And quite often the mums are white as well. And it's sort of, well, if you're not teaching us from day one, I only started in January, so it really is the very early stages for our cohort. If you're not teaching us from day one how to recognise things in a variety of women and a full sort of ethnic demographic, that's just such a basic problem, isn't it? If we're only seeing what these problems look like on white babies, of course there's going to be problems down the line if we aren't taught from an early stage to recognise what this looks like. So, and luckily we are asking, saying, oh, can you tell us what that would look like on someone with darker skin? And the answers are there, but it's just that fundamental sort of almost not thinking of, oh, I should also mention this, that it would look like this in this circumstance and this in other circumstances.
No, I agree, and I totally agree. And thank you, Renee, for sharing that, because I was trying to find the title. There is a book called Mind the Gap by Malone McClendey, and it does focus on different skin conditions, on different colours of skin, different types of skin. So definitely check that out. The title's in the chat if you want to look it up. Anyone else would like to share their thoughts and feelings about what needs to be done to change these disparities?
Hi, I'm Cecily. I'm a second year student from London.
Hiya.
And for me, it's really about making myself feel uncomfortable to do things that I've spent so long avoiding, or not even purposely avoiding, but it's just been easier to just oh, you know, that's not my problem, and it is my problem. It's very much my problem, and so yeah, for me it's about being proactive and brave is not the right word. That's not what I'm not saying it's brave to stand up for something. You know what I mean? I'm not using that word, but yeah, for me it's about pushing myself, feeling uncomfortable, and advocating for the women that I need to advocate for.
That's right.
That made some kind of sense.
Yeah, that makes sense. Thank you for sharing. Being a midwife is part of that is advocating for the women that we care for. So definitely speak up if you see something or you hear something that's not quite right, or you feel like someone's being treated a certain way because of their skin color or where they're from. Aruna has said in the chat, really encouraging to hear the voices of so many students representing our future leaders. And I agree. I think us as students, we're the future of midwifery, and we really have it in us to create the change that is needed in the system. Would anyone else like to share how they feel?
Hi, my name's Liz. I'm a university lecturer.
Hi, Liz.
And it's really interesting to come on here and listen to the voice of students about how you're feeling and how it's not broached within your course. And I'm really glad that I came, because now obviously this is something that then I can raise with the course leader and everything else about how students are feeling, and maybe try and make a difference and start with the education side. So yeah. Amber, if you have any ideas, I would be more than happy to catch up with you afterwards about how I can change and help my students.
That'd be great, Liz. I don't know how we'd get in contact, but do you know which uni are you working with?
I'm at Birmingham City University.
Okay, so I'll try and get in contact after the conference. Is that okay?
Yeah, or I can always put my email in the chat if you
don't mind sharing.
Yeah,
that's absolutely great. Thank you.
Yeah, that'd be fine.
Anyone else want to share how they feel?
Yes, my name's Claire Williams. I'm the continuity lead at City Hospital in the city of Birmingham. Our demographics in this area are heavily weighted towards ethnic minorities. We have a sort of a 67% client base, which comes from BAME communities. So it's quite important for us here. Sometimes it's just the simple things, it's the little things, and like it was said earlier, it's not making assumptions of what we think are the barriers, it's actually speaking to these communities and finding out what the barriers are. And sometimes it's as simple as not being confident to call the triage department, not knowing what to say to the triage department, not knowing how to vocalize what they're feeling and what's happening to them. So it's not always about taking on a massive project. Sometimes it's just looking at the little individual problems and addressing them.
I agree. Thank you, Claire, for sharing. I just want to touch on something that you just said. I try and stay away from the acronym BAME because it kind of groups us all together, and we all have different needs and we all have different experiences. So I know your intention wasn't bad, but just going forward, if we could all refrain from using that acronym, that would be great.
I apologise for that. It was
fine.
not planned in my head what I was saying, and so I appreciate it. It's not, it's not acceptable.
That's fine.
Sorry.
No worries. Thank you for sharing. Michelle Septo, who's one of my lovely lecturers, has said in the group chat, but let's not forget that poor cultural attitudes can be shared I think she means by all cultural groups. I agree. Everyone, no matter where you're from, we can have a bias or some form of discrimination in us. So we all, no matter where we're from, we all need to work on that and not let that not affect the care that we give. Does anyone else have anything they'd like to share? So Laura has asked in the group chat, could I ask what a good alternative acronym, the acronym BAME is? Well, we don't need to really necessarily use acronyms. We could say Black people, Asian people, acknowledge where everyone has come from. If you're talking about different cultural groups collectively, I guess you could use people of color, but I think it's really important to acknowledge where everyone is coming from. Does anyone else want to share how they feel about these statistics or what they'd like to see change? Hiya.
Well, sorry.
Hiya.
Yeah, so I'm almost finished, as I said before, and I am a student at BCU. One of the issues that I found was that I'm from South London, and obviously I moved from South London to Birmingham because I was promised that, oh, it's diverse. But one thing that I struggled with was the lack of inclusivity, especially as an African, as an African woman. You know, the main ethnic minorities there is Afro-Caribbean or Asian or other white ethnicities, not necessarily indigenous from the UK, but from Romania or anything like that. In the university, one thing that I struggled with was the lack of cultural sensitivity that a lot of the lecturers have in terms of representing what brown and black students needed. Especially in a lot of our classes, it was, let's say if it's a class of 70 students, there may be to fit the status quo, there'll be maybe 4 Black students, 2 Asian students, and 2 other ethnic minority from different parts of the parts of Europe or different continents of the world. Now, to a lot of them, they'll say, "Oh, but this is quite diverse." It's not diverse if it's not inclusive.
I agree. I think we all need clear definitions on what diversity and inclusivity is.
And one thing that I found was I suffered quite a lot of racial microaggressions from the students. A lot of the students were young, it doesn't matter regardless of age, but a lot of the students didn't really try to hide their prejudices in terms of how they would communicate with us and everything like that. So if you, challenged them, you were seen as intimidating and aggressive.
Yeah. I think that's another issue, isn't it? If we address it, then we're troublemakers and we're just trying to be disruptive, isn't it?
Absolutely. And then your confidence is slowly gouged away from you because
exactly. There's gaslighting, and then you start thinking, is it me?
Absolutely. And as much as we need more minority midwives, not just black African. We need more Southeast Asian, East Asian.
Yes.
We need across the board. We need that representation, but it's difficult when the whole education system is not catered to you. So that's because it was brought up earlier that we need more. Somebody said that we need more ethnic minorities to speak up in class, but it's also from the top in the education as well. How does the trickle down effect isn't working anymore, in terms of how do we address all of these inequalities if there's blatant inequalities in the education system as well, in terms
I agree.
in terms of who's in charge, etc., and what they truly want to learn and pass on to us to go on and go forth and help other people.
No, I agree. And for any lecturers out there that are listening to us talk today, if a student comes to you and saying that they're being racially abused in placement or in uni or by any other students, please, please, please take it seriously. Because I've heard numerous situations where it's just brushed under the carpet and they're basically told to get on with it. So we have a shortage of midwives. So let's not run them out of the course. Let's support them, encourage them, and be there for them when they really need it the most. Thank you, Laura, for sharing.
Thank you.
Anyone else like to share?
Amber.
Hiya.
Hi, my name's Helen. I am one of the university lecturers listening. And what you just said about supporting students who come to us who've experienced racism, either directly towards themselves or they've heard in how staff have spoken about a woman. So we've had a group of students come to us this year and we took that very seriously and we took it into the clinical placement. And we are working with the clinical placement over this, but what we need to do is we really needed to understand a broader experience of the students. So we set up some listening events for the students.
Okay.
They could come and share with us. They had the option who they shared with in terms of the lecturing group. So you can't see me, but I'm white European. But I do have a personal background of being a refugee, family of a refugee, so racism in our family. So I have some understanding, but my skin is white. Anyway, we set up these listening events for the students. Actually, the students told us they wanted it and they would come, but it was incredibly difficult to get them to come.
Okay.
But do you have any ideas how we could, and that it wasn't just me, so one of my co-lecturers is an African, a British African woman.
Yeah.
But, so, you know, the students actually came to me, which was amazing, but it wasn't just me there. So, you know, we know the students are confident to talk to us and yet they didn't come. And the other thing is that we're curriculum planning where we are at the moment. So for those of you that don't know what that means, the curriculum rolls over for several years in much the same way, and it's very difficult to make major changes while the current curriculum is on. But we're just about to, well, we are rewriting it for 2022. This is very much a topic within our curriculum, how to overtly celebrate diversity within our new curriculum.
That's really great. Thank you for sharing. Going back to trying to get students to attend these open conversations you're having, that's a bit of a tricky one. I think just keep trying, because it is very daunting and it can be very traumatic to relive experiences that they might have. They might be scared about the response they get if they share how they feel or what they've been through. So I know it might seem like no one's listening when you've approached the situation, but please keep trying and please keep supporting. Jade Sullivan, who's going to be speaking later on, has just shared with me an article from the BBC, and it says miscarriage rates are over 40% higher in Black women, the study suggests. So we need to probably explore why that is as well. Does anyone else have anything they'd like to share? Just have a look at the chat as well.
Hey.
Yeah.
Can I just respond to what was just said about like students not turning up to these open events? I think like it's really tiring as the oppressed person to have to talk about these issues and have to figure out like how to deal with it. And I think knowing that the people that you're going to, probably majority of them don't empathetically understand what you're going through. They might be sympathetic, but they don't actually understand what it is to be discriminated because of your race. I really understand why people might not trust that experience. Like even if it is an open space where you can come and talk about your experiences, it takes a lot to actually do that. And I think basically there just needs to be more representation. You need, like, I feel as a student, I need to know that I can go to someone who knows what I'm talking about and not have to explain it to them in a way that they understand. And I think, yeah, just like you said, Amber, just keep doing it, but really push for that representation in the uni. And I know it's kind of like this positive discrimination thingy, or I don't really know the best way to go about it, but like from my experience, I need to have people that are representing me that know what I'm going through. And I think even if you feel like people aren't turning up, that space needs to be there, because even if it's just one person that goes, that is really important. And I think this response of like, oh, we tried. I'm not saying this was your response, I don't know who was talking, but yes, response of like, oh, but nobody came. I mean, if it's the first time you've done it, it's not really surprising that nobody's come, because because they probably don't assume that it's actually going to lead to anything. So I think it's a process that needs to be put in place, and we need to keep pushing for it, but we need to that representation. And I don't know how that can
coming in and out.
happen, but sorry.
That's good.
So
yeah, I mean, that was kind of my point.
No, I agree, representation is needed. And Priti Patel, who's my cohort lead, has written in the chat, you are right, Amber, university lecturers do need to support students who experience racism, but the challenge is empowering the students to work with the lecturers to support a way forward. And this is very sensitive, this is a very sensitive situation, but from a lecturer perspective, it is difficult to support without the students' input to take it further. So we do need to address this. Yeah, I agree. It is a two-way effort that needs to be done. So if you're a student and there is an opportunity for you to talk about how you feel when it comes to racism or any experiences you have faced, I know it's just super, super hard to talk about, but if you can, I really encourage you to do so and use the channels of support that you have been provided. Representation is needed, so it would help if someone is in that space to help you and they can relate to what you've been through.
Yeah, I just wanted to come in. Is that okay, Amber?
Yeah, of course, please.
Hi, I'm Maury. I'm one of the midwives in London. And I just wanted to say, just coming off, I think it was Danielle that was speaking.
Mm-hmm.
If you ever feel like you do want to talk to somebody, I feel like maybe this might be a long shot, but maybe there should be some mandatory training around racial inequalities and racial issues. Maybe could be outputted so it's spoken about again and again and again, and then it makes people from all different backgrounds more comfortable to talk about these issues and not shy away from it. Maybe that might help in that aspect.
Yeah. You need mandatory training for the staff and the universities?
I think both, to be quite honest. Yeah.
I agree. I totally agree.
Yeah, I agree too. I think everyone from the university to hospital trust need to be trained in the consequences of the racial inequalities that we are seeing. Thank you guys for sharing. There's time for one more person to share their thoughts before Sarah will talk to us. Is there anyone else that want to share?
Yeah, my name's Carla. I'm a first year student at LSBU. I'm doing the short course. My placements are at Guy's and St Thomas's, and I'm lucky enough to be one of the first 100 staff and students that are going to be part of the first 5 times more training by the charity. So they're trialling the training at Guy's and St Thomas's first, and then hopefully it will be a national training. And it's actually next week, so I haven't been part of the training yet, but I just wanted to highlight that is, one of the first steps of its kind, really.
That's really amazing, and I'm so glad one of my fellow LSBU midwifery students are doing it. So well done, Carla.
Thank you. Yeah, I'm chuffed to be going, to be honest, because it was quite competitive. So yeah.
That's really good. Maybe we can get in touch and you can let me know how that goes.
Yeah, for sure. It's called, someone just asked in the chat, so it's called 5 times more. And it's a charity that's London based. It was created in, I think, the latter part of 2019. and it was on the TV recently.
It was on the Dispatches, wasn't it?
Yeah,
Yeah.
yeah. Scandal. So yeah, I definitely recommend looking it up, and hopefully it will come to some more trusts.
That's great. Thank you for sharing, Carla.
Amba, just quickly to jump in on that, I'm Laura. I'm the trainee consultant midwife at St. Thomas's, and I'm helping to organise the event.
Oh, yeah.
So we're going to be auditing the training event with Chloe and Tanuke and the staff that will be attending, and we'll hopefully be presenting that. But that's definitely the plan for it to go national. So watch this space, and if anyone's interested, if you attend access the 5 times more website, I'll put the link at the bottom. You can contact Chloe and Tanuke and try and get it to your trust as well, because this isn't just a London-based problem. We have to make this national.
I agree. Thank you for sharing that, and thank you for sharing the link. I'll definitely discuss that with my CPS and see what we can do at my trust. So it's nearly 11:45, and Sarah, a lecturer from my university, a senior midwifery lecturer, Sarah Esegbona-Adeigbe, will be talking to us about what can be done in midwifery education to create change. So that will be in 4 minutes to be precise. So we have a bit more time to have a bit more of a conversation. Does anyone else want to add anything before we wrap this convo up? So I have a comment in the chat saying, I recently taught 3rd year's cultural competence, and the most challenging aspect was getting white students to recognise white privilege and systemic racism in maternity care. Very interesting, but very emotional and disheartening also. Lots more work needed to be done. Yeah, I think getting people to understand what white privilege is a difficult task. Just because privilege, I guess, in people's minds, they think that you have all this money and you live a life of luxury and everything is very easy for you. Obviously, we know that white people don't always have an easy time, but when you compare their experiences to women of color, they definitely have it easier. And if you're not sure what I'm talking about, please go out and do some research and talk to other people and really understand what it means to be privy to white privilege. Okay. Let's see what else is in the chat. So Alice has said in the chat, I completely agree. I'm a white midwife in a same-sex marriage working in a predominantly white area. Due to this being such a white area, there is a huge misunderstanding about racial inequality and the racism behind this. Often it feels like I'm the only voice in my trust. I'll try and see if I can get something like this to set up so more of my colleagues can understand. Thank you, Alice, for sharing. Yeah, you just have to keep educating people, keep talking about it, keep educating them. Some people won't want to listen, some people won't get it, but don't feel disheartened, just keep going. Okay. So I think it's now time for Senior Midwifery Lecturer Sarah Esegbona-Adeigbe to talk to us.
Good morning, everybody. Can you hear me?
Yes,
we can hear you.
Yeah. Lovely, thank you. So I'm just going to share my screen, if you just bear with me. and hopefully you can see my presentation.
Yes, we can. Thank you.
Thank you. So thank you, Amber, for inviting me to talk on this session on racial inequalities in maternity services. So the session I'm going to cover today is very broad, but very relevant to today's conference on how midwifery education can help reduce racial disparities in maternity care. I work with a very diverse team at London Southwark University. We are a very supportive team. And of course, being in the central London location, we have a very diverse student body. We are proud of that. And we cater for a very diverse childbearing population. So this is really relevant, having this talk today. And it's really relevant that this conference is being held today. So first of all, let's talk about the term racial disparities. So this refers to a difference that may or may not be related to discrimination. And when you think about the term racism, it means different things to different people, but racism is attributing different identities or abilities or characteristics to people solely because of their race, their ethnic minority background, or where they're from or their culture. And then when you think about discrimination in a very broad term, it's actually treating people from a particular race, culture, or background differently. And normally when you think about discrimination, there is positive and there is negative discrimination, but we know in the world today that when we talk about discrimination, it's normally negative discrimination. And if you think about racial disparities in relation to health, I've picked up some key issues that have arisen over the years, decades, and centuries about how there has been a history of racial disparities in health. And obviously, I'm going to talk about James Marion Sims, otherwise known as the father of modern gynecology, who operated on enslaved women in the 1800s. One of the main things that he did was looking at fistulas in enslaved women and how to perfect gynecological and obstetric procedures. And of course, we know today that he developed what we call the Sims speculum, which is still in use today in obstetric and midwifery practice. Now, there has been concerns about how these procedures were conducted by Dr. Sims. And obviously, the excuse he gave was that there was willingness from the enslaved woman to have these procedures done, and that they had actually, in effect, consented. And I struggle with that because obviously, when you think about enslaved women and consent, they don't actually fit within the same sentence. Then if you go forward to the 1930s and look at the Tuskegee study, this was a study of over 600 Black males in the USA. And the purpose of that study was to monitor and observe the progression of syphilis. However, there were 600 males and a total of 399 of these males had syphilis. However, they weren't treated. They were given health benefits, amongst other things, but they weren't told that they had syphilis. They were told that they had bad blood, which obviously to them meant that they were anemic or maybe they had fatigue. And even though there was an acceptance that penicillin could be used for the treatment of syphilis in the 1940s, these men were not given the treatment, and this study carried on for 40 years. Moving forward to 2019, the Workforce Race Equality Standards, looking at inequalities in the NHS, in their most recent report has still highlighted that there are ongoing inequalities in the NHS. There is still racism and discrimination. And then if you look now at today and the COVID-19 pandemic, Public Health England identified that there was increased risk and disease progression in people from Black, Asian, and ethnic minority backgrounds. So there are issues already regarding health disparities. Now, midwifery education is important in addressing health disparities because obviously it's recognized that good, consistent quality midwifery care has a vital role in the reduction of maternal and neonatal mortality. The NMC has now devised new standards for midwifery proficiencies because it's expected that women and the public need to be, reassured that they're going to be receiving the best quality midwifery care. And with these standards, the NMC state that they are contemporary and they are fit for purpose. And then, of course, looking at the people who are going to deliver that education, we look at our midwifery body. We need to have experienced, well-educated midwifery lecturers who are able to deliver high quality midwifery education. However, when we look at the most recent maternal mortality report from Embrace, it came up in December 2020, we noted there are still issues with disparities. If we first of all look at the stillbirth rates as one indicator, we know that the stillbirth rates for Black and Black British babies are over twice of those compared to white babies. We also know that this is the case, that there is an increase for Asian and Asian British babies as well, of being more likely to have a stillbirth. If we look at the 566 women who died in the last Embrace report, you can see that out of the 566 women, 119 of them were from a minority ethnic background, 52 were non-UK citizens, 216 were born outside the UK, and 22 were non-English speaking. So Marion Knight in her report stated that there is a constellation of biases, but you can see some of those biases are related whether directly or indirectly to race. So let's look at current midwifery curriculum. We need to ask ourselves these questions. Are there failures of efforts to improve student diversity within institutions? Also, is there a failure to address long-standing adverse outcomes in women from diverse backgrounds? And is the curriculum Eurocentric? So these are the debates that's happening today. And this is what midwifery higher education institutes are trying to address in their curriculums. And then we look at current midwifery practice. Is there a workforce that is able to accommodate the needs of a diverse childbearing population? And are there systemic biases that are allowed to take root and grow? So these are the questions we need to ask ourselves. The NMC states we need to be fit for purpose and fit for practice. But are we creating midwives that are fit for purpose or fit for practice? And also, when we look at our midwifery workforce, is our workforce able, or are they giving us the tools and the skills to be able to cater for a diverse childbearing population? And this is something that I'm really passionate about. Obviously, I come from a Black African background. I'm a second generation Black African. But having that history of knowing that women have been dying, and this has been for over 20 years, that there's been disparities in maternal mortality and also disparities in perinatal mortality for 20 years. And we still haven't been able to address that. So midwifery education is really important. We can get it right and we need to get it right, but how can we get it right? So going back to what a Eurocentric curriculum looks like. In a Eurocentric curriculum, students are expected to engage with content that does not relate to them. Obviously, if you've got a diverse student body and we are actually teaching them about how to look after women from a diverse background, are we giving them the correct content? Students are taught that Blackness is a problem as well as a deficit, which is another issue. When you look at risk factors, predisposing factors for many of the obstetric or midwifery complications, you'll find that there is ethnic minority women, Black, Asian women, tend to automatically sit in that arena. And when I'm teaching complexity, which is one of my modules, I always say to students, if you're going to answer an exam question and you want to look at predisposing factors, if you put in Black or Asian woman, 90% of the time you're going to be right about that. Then we need to think about lack of culturally appropriate assessments. Are we teaching students about how to do these culturally appropriate assessments? And then importantly, is there a failure to acknowledge systemic racism and discrimination? Do we have to have those conversations? And if you look at a Eurocentric curriculum, no, we are not. And then, do we have a diverse academic teaching staff? And there's some statements or suggestions that a Eurocentric curriculum is because there's no diversity in the academic staff. So global education, when we look at global education, there has become a challenge, a widespread challenge, and an assumption that the most valuable knowledge and the most valuable ways of teaching and learning comes from a single European tradition. Some people will question that and say that's not actually the case. And some individuals who are outside of Europe actually say this is actually the case, that we do model our education on a European tradition. So let's talk about decolonization, because this is something that's become the new it word in the last few decades. It's been around for quite a few decades, but it was highlighted again in South Africa when the students protested against the Eurocentric curriculum about why is it that when you're teaching us, for example, about history, you're not talking about the history of our African ancestors, you're not talking about history of white ancestors. So decolonization is a way of thinking about the world, which takes colonization, empire, and racism, and we situate these phenomena as key shaping forces of the contemporary world. So therefore, not erasing the history of colonization, acknowledging it and bringing it into today's worldview. And basically, it's about alternative ways of thinking about the world. And that's what we need to do. If you think about what a colonial curriculum looks like, a colonial curriculum is also an inaccurate curriculum because it doesn't address the impact of and the history of colonization on today's healthcare, for example. When we think about decolonization over inclusivity, we need to think about, does an inclusive curriculum or a diverse curriculum, is that more suggestion that outsiders should join the club and that their views should be incorporated into the club? Or rather, what we should be doing is looking at, we were colonized, this is the impact of colonization, and we now need to bring that into the current state of play, rather than putting it into the past and just trying to include people from different backgrounds into the current agenda. So decolonization versus inclusivity. This means meaningful engagement with decolonization would require reassessing the curriculum, attainment, gaps, and representation. And one of the things we need to think about is our recruitment. Are we recruiting enough from different diverse backgrounds? Because we do have a diverse tribal population, so therefore the workforce should be diverse as well. Does decolonization sit in the same sentence as widening participation or equality, diversity, and inclusion, or should it be a separate agenda? Because if we are putting it in the same sentence as widening participation and EDI, this would probably lead to policies which lead to more inclusive reading lists and a narrowing of Black, Asian, and ethnic minority awarding gaps. However, it suits the agenda of both colonization and diversification, but doesn't actually address the issues that arise from being colonized in the past. So our decolonizing lens means that if we're looking at a curriculum in that way, we need to have a teaching practice that is engaged, anti-racist, and decolonial. We need to start talking about problems openly, such as racism, white supremacy, and colonization. And if we think about decolonized learning, we need to have learning that prompts us to consider everything we study from new perspectives. Think about the past, think about the present, and think about the future. We also need to draw attention to how it is often assumed, or often the case, that curriculum is presented from only one worldview, and that's a European worldview, which is male, white, and heterosexual. And if we do consider multiple perspectives, then we can start to make space to think about carefully what we value. And if we do start to decolonize, it helps us to recognize, understand, and challenge the ways in which our world is shaped by colonization. And it also, importantly, to midwifery, allows us to examine our professional practices. So one of the things we need to think about is how we can make our midwifery curriculum culturally appropriate. Now, we think about things, cultural competency has been around for decades as well. Papadopoulos was one of the leading persons in cultural competency in nursing, and that's now transcended to midwifery practice. Now, cultural competency has been belittled in some aspects as not being really relevant, but I think cultural competency does have a place in midwifery education. It's about midwifery cultural competency knowledge. It's about cultural sensitivity, cultural awareness, cultural desire, cultural encounters. One of the key elements of cultural competency is cultural knowledge, having some cultural knowledge. And cultural knowledge has been used very sensitively, because it's not about acquiring knowledge about a particular culture, because obviously every woman is an individual. It's actually about having that knowledge to be able to start those conversations, having that knowledge and able to have this culturally sensitive communication, and also having that knowledge so that you can start to become culturally aware, which is why sometimes cultural safety, which is an umbrella term which sits above cultural competency, is probably more appropriate. And so cultural safety is about protecting the cultural identity of the woman. And what it does is that it allows the midwife practitioner, or the student in this case, to look at their culture, look at their biases, look at their preconceived ideas, and recognizing that it may be different to the woman that you are caring for. And so therefore, you're not putting those beliefs and those values on the woman and her family, and letting her tell you what she values and what she believes in, and using that as a starting point to provide her care. So that's why cultural safety is really important, because cultural knowledge, because we're so diverse in the UK, there's over 200 different ethnicities, languages, diversities in London alone. And so therefore you can't acquire cultural knowledge for every woman that you look after. But if you are culturally safe, what you can do is start to look at yourself as an individual and know that you are different to the person you are caring for, the woman you are caring for, and be able to provide the care which is culturally safe. And it's a woman who decides that the care is culturally safe, not you. So it's about having those conversations as well. And then we talk about culturally appropriate assessments. Now, I know in the previous session with Amber, someone did raise the book that was written by a medical student at St. George's called Mind the Gap, which is a handbook of clinical science in Black and brown skin. This is a medical student that when on the medical course, when was being taught about degrees progression, diseases in in white skin predominantly, highlighted or raised the question, but what about Black and brown skins? How would I recognize this disease or disorder in Black and brown skins? And was not given an answer. And this medical student went out and actually explored the science in Black and brown skin and developed this book. Now there's an issue here, isn't there, that this had to be devised by a medical student in today's world. This is around 2019. Why wasn't this done before? Why has this not been recognized as an issue in medicine? And the same thing can apply in midwifery as well, whereby we talk about the gynecoid pelvis, but we do know that the majority of non-gynecoid pelvis are found in Black women, Black and brown women. When we think about things, jaundice, we know that to recognize jaundice, we're teaching students how to recognize jaundice in predominantly white skins, but also we need to think about how does it manifest in Black and brown skins. Then when we talk about if someone is becoming hypoxic, how do you recognize someone is becoming hypoxic in brown and Black and brown skins compared to white skins? So these are all the things that we need to incorporate in the curriculum, these culturally appropriate assessments. So what we're aiming for is a non-Eurocentric curriculum. So it's actually more than just changing the curriculum, because universities can prescribe new reading lists and lots of different materials, but it's also about the academic attitudes as well. Are they going to embrace that we need to change the curriculum and make it non-Eurocentric? Do we need to recognize the impact of colonization on how education is delivered today? Now at LSBU, we are currently doing our curriculum to start in September, this September 2021. Our midwifery team is very diverse. When I look at my team, we come from very different backgrounds, and I think that gives us an advantage of addressing how we can change our curriculum to make it more contemporary. And it's really important that we have to recognize our own biases, our own prejudices, and our own beliefs and values, and how we can use that to actually change the curriculum and do a really effective curriculum change so that we are addressing these disparities in healthcare, particularly around maternal mortality. Now, when you look at the recent Embrace report, they said that out of the 566 women who died, 49% had good care and the outcomes may not have been changed. But in about 29%, a change in care or improvement in care could have changed the outcome of this woman and probably prevented them from dying. So this is really an important issue. And when we talk about maternal mortality and stillbirth rates, for example, that's not the only thing. We need to think about morbidity as well. Women are suffering morbidity from the fact that they are pregnant. And it's obviously higher in Black and brown women, Black women, Asian women, minority ethnic women. So that's important. So when we're looking at addressing the curriculum, we need to look at how are we going to create a curriculum that is effective in caring for a diverse childbearing population. So open dialogue is really important. We need to create spaces and resources for dialogues amongst all members of the university on how to imagine and envision all cultures and knowledge systems. And that's what we are doing now at LSBU. We're trying to look at how we're going to address it. Is it going to be by modules? Is there going to be a specific module that's going to address racism, discrimination? Are we going to look at making sure that when we're doing any type of assessment of the mother or the neonate, we're going to make sure that it's culturally appropriate. We're going to give the midwives, student midwives, the skills and the tools to be able to recognize differences amongst our diverse childbearing population. So it's important that it's not so much about the content and having the open dialogues, but also having dialogue, but also about how it is taught and how it frames the world. Very, very important. And so a partnership approach is recommended to learning. So teachers learn from students learn from each other, students learn from the teaching, and the modelling of culturally competent teachers and professional colleagues share with and learn from each other. And so therefore we all learn by applying our learning in practice. Now, our focus on midwifery education, that we also need to think about mandatory training for midwives in the clinical area. And I did ask some of our CPS in our trust partners, what does your mandatory training consist of? And I know that the majority of them did say it doesn't consist of culturally appropriate assessments. It doesn't consist of discussions about racism and discrimination. And that's really sad because we know racism and discrimination is out there. We know it is within our NHS. It's been highlighted. There has been recent reports that come out to say that actually it's not the case, but actually it is there. If there are health disparities, then not far behind that, there's issues around racism and discrimination. Women's voices not being heard, women's concerns and views not being taken seriously, midwives not using their intuition, or sometimes, just for a better word, basic common sense to know that if a woman says she's in pain, if a woman says she is not happy about something, explore it with her, take it on board. It will get you halfway to understanding what the issue is. But when you don't start to listen to a woman, you don't start to explore her concerns with her, then you're losing half of the clinical picture. So I'm going to end it there. We've got time for some questions or discussions. So is there anyone who wants to raise any points from the presentation or
Sarah?
any questions? Yes.
My name's Liz. I'm a university lecturer at BCU. It's really interesting your talk. I'm from a white background, so it's really interesting to hear your background as well, just to how we can promote more inclusivity. If you were thinking of doing, say, racism as a module, how were you thinking of assessing it?
Well, I think first of all, we need to think about, just raising it basically in the first instance. Wouldn't be so much assessing it, so it wouldn't be part of an assessment per se. It would just be just having this open dialogue, discussing racism, discrimination, that is out there, that is present, and obviously giving students the tools of how to tackle it when it arises. Because sometimes racism, as we already said, it can be covert and overt, and the most dangerous type of racism is the covert racism. I always say to students, my colleagues, if someone's going to be racist, I prefer them to have, to be overtly racist towards me, because then I know what I'm dealing with. But when it's covert racism, it can be very, very difficult. So that's the thing that we just need to highlight with students.
Lovely, thank you.
I think Femis has a question. Their hand is up.
Yes,
Okay.
yes. I wanted to say that was an utterly amazing. That was just what I needed to hear. And thank you.
Great.
It was honestly, I really needed to hear that, because I thought that I saw a lot of that happening around me, and I thought it was just me being me, but it isn't. And I am white, but I have my grandfather was from Sierra Leone, an albino as well, and yeah, I just wanted to say that was everything I needed to hear, and thank you so much for your work. Thank you. That was it really. I just wanted to say thank you, because that's great. That's incredibly helpful to me as a person going into midwifery, and I'm really grateful for you. Thank you.
Lovely. Thank you for that positive response. Thank you.
Sharon?
Yeah, I found that really helpful. It's just reminded me that the decolonization process has to start in our minds. I'm a white midwife, and you know, it's easy for us to think, but I'm a nice person, I'm doing my best. But it's that old thing of fish can't see water, isn't it, about culture? I have to bring like a real lens, a real awareness and consciousness to what goes on in my mind, and therefore what comes out of my mouth with the best will in the world. It's having to go back and see things in a new way, and maybe a way that we've never learned to see yet, but we have to.
Yeah, and you know, it's not just in midwifery education. Decolonization is actually being addressed in obviously other professions. So, and all curriculum actually in the UK has been addressed. And obviously, I know in the previous session, one lecturer said that, you know, obviously now with the old curriculum, but they're going to be devising a new curriculum. And that is a great time to start thinking about, right, let's look at our curriculum. What do we need to change there? What are our students asking? What do our women need? So that's some of the things we can do. But if you are having to stay with the old curriculum, it still can be input. So as I said, I talked about racism and discrimination, talking about that maybe as cohort days, or maybe just having it as part of modules, probably public health, as you know, one that comes to mind, public health related modules. So this is the things that we can start to do. Because I must admit, when I did my training, we never had anything around racism and discrimination. I knew about it, obviously, coming being a Black African living in the UK. Also, I worked in the States as well, and I saw it there as well when I worked as an obstetric nurse in the States, that there is discrimination. And the funny thing about it is that it wasn't my white colleagues I worked with in the States who told me about this discrimination. It was my African American colleagues, but they would only speak to me because they saw me as being the same as them. So it's a conversation that needs to be had, open dialogue.
Marissa?
Hi, I'm Majisa, a student midwife from the Netherlands. And here in Amsterdam at the Midwifery Academy, we started a task force to address racism and discrimination and to achieve equity. One of the things that we're going to try to do is to enlarge diversity within the population of student midwives. But I mean, I really, really loved your talk. And I think that what you said about decolonization is so important. But I'm just wondering, like, where do you start with decolonizing the curriculum? Do you have any tips? Because it seems like such a big task.
It is a big task, and it can be a little bit overwhelming when you think about it, because obviously we've got hundreds of years that we need to probably, you know, address.
Exactly.
Hundreds and hundreds of years we need to address. But it's obviously talking about, when you talk about racism and discrimination, talking about how our colonial past has impacted on how we deliver our services today, whether it's in education or healthcare services. And then again, talking about how that has created this racism and discrimination. There is a link between the two. And I think when I did a Maternity Midwifery Forum talk in last year, there was in the chat, there were some comments about, well, no, there's no link between slavery and health disparities in the UK today. And there was a kind of like a little bit of an uproar within the chat about, and mainly between Black and brown midwives and this midwife who came from a white background, and saying to her, but you know, there is a link and you have to accept that, but the person wasn't accepting that. And so I think it's understanding there is a link in the first instance, and how this has impacted. It's impacted on our medical model of care and our midwifery model of care. We can't deny that. Mm-hmm. Because what we're teaching students today, majority, not everywhere, is that it's a Eurocentric curriculum, and that needs to change.
Yeah, thank you. That's a start indeed.
Yeah. Are there any more questions? I'm looking in the chat as well. So when we talk about discrimination, we know that there's discrimination. There are many different types of discrimination. So it's not just racial discrimination. We've got discrimination around sexuality, gender, age, religion. So that is important as well. Addressing that it's not just about racial discrimination, even though that is one of the key ones, but thinking about other things that make people different, and making sure that we are addressing that within our curriculum. That's very important as well. I just wanted to say that. So someone's talked about teenage pregnancies. Is there discrimination there? Yeah, well, you probably can answer that yourself. Do white young girls get better care than black, brown pregnant young girls? Is that a question or is that a statement? I know you put it as a question, but is it a statement? Is this what you have seen? This is from Delia Mohammed. It's the question. Okay, that's fine. When you think about people who have characteristics that are from two elements, so they're racially different, and maybe there's a age difference as well. You can see how, you know, this, when you look at the embrace report, the systematic biases, a constellation of biases, because when I looked at the embrace report, it wasn't just around ethnicity, it was also around social background, age, educational status, majority of things that put women at risk during pregnancy and childbirth. So I guess the answer to that question is yes. Any other questions from anyone else?
Hi, Sarah. Sorry, I didn't know how to, I couldn't raise my hand for some reason, so I'm just going to jump in. Thank you so much. It's really, it was just really, really interesting. And like someone said, exactly what I needed to hear. And I wanted to ask a little bit about the cohort, overt, covert racism, because I've experienced, I'm a white student midwife, and my experience has been that I was in a situation where the woman didn't want to speak to, I was working with all black and brown colleagues who are obviously not student midwives, they were qualified midwives, and this woman who had just given birth was on the postnatal ward, only really wanted to speak to me, which was obviously a racial issue. And so navigating that, I didn't know quite how to navigate that situation as a white student midwife. So yeah, I was just wondering if there were any, obviously my instinct would be to say something, but then I didn't want my colleagues to then have to look after her, to make them uncomfortable, but I didn't want to enable her behavior and her thoughts, if that makes sense. So yeah, I just wanted to put that one out there.
Yeah, I mean, that's a difficult one, because obviously if someone says, I don't want this midwife to look after me, I want you to look after me, and the person saying that is a white person, and the person who doesn't want to look after her is a black or brown person, then you automatically think, or it's easy to think that, is this racism? But I think sometimes to have the conversation with the person first to find out why is important, because in some cases there may not be racism, it may be something else. But it's having that conversation with them, you know, in a professional way, to discuss with them. Oh, I noted that you said this. Can you let me know why you said this? And obviously, if it is racism, or you think it's racism, then it's about obviously escalating that as a concern, because we do know that women, it's their pregnancy experience, and you know they are entitled to have the best care that they perceive they can have. from an individual, and if they feel they're not safe in an individual's care, then they have the right to change their carer. But it has to be fair, and racism and discrimination shouldn't be tolerated. It shouldn't be tolerated from midwives to women, and also from women to midwives as well. It shouldn't be tolerated. So it's something that has to be addressed once you know that is the case. I just want to clarify that we need to make sure that is the case.
Yeah, thank you. That's very helpful.
Any other questions? I'm just looking in the chat now. I'm just. Also, someone's talking about patriarchy and how it affects our care in the terms of decolonizing education. Do you want to expand on that? This is Rua.
Hello.
Hello.
Hi, Sarah. Lovely to meet you and lovely to chat with you. Yeah, it's just in terms of the internalized, I think a lot of women, we don't realize it a lot, it's the internalized misogyny that I've seen as both a student and caregiver with women. When we unconsciously make, our conscious bias to other women, and just like, oh, she's like this, let's say in terms of social class, oh, she's like this, I'm not going to give her the best of the care because she's not that educated anyway. When as women to women, we should just treat each other as women to women. It should be treat others as you would like yourself treated. It's really quite simple, but with the effects of how patriarchy has affected us, especially Black women, because of what you brought up earlier in your slide, in your presentation, was about how the speculum came about and how it truly affected Black women, and what our pain is or what it isn't. It's also due to patriarchy and just how men view women, and how sometimes we view women as well because of the way that men view us. So it's a never-ending cycle of we are doing to others what we don't want us done to ourselves. So I think that will also help in our education with how to give just as good, the care that we give to white women, how we also give it to African women, Caribbean women, East Asian, Southeast, all women. And there are some people out there who may not identify as women, but they have uteruses. So it's how we also treat them as well. It's how we treat everybody in the maternity care services. So I think we do need to, on top of intersectionality, intersections, racism, discrimination, we need to definitely bring in patriarchy as well, and how other women treat other women.
Yes, so thank you for that point. That's a good point that you raised there. It is important to think about other aspects outside of racism and discrimination. And also it's important as well to think about the woman you are caring for, whether they identify a woman or not, but if they are coming in contact with maternity services, just being aware of your own biases, your own prejudices, and how you perceive women and how you care for women. It's really, really important to have this understanding that everyone is different, okay? But everyone is entitled to the human rights, and the human rights is to have the best quality care given to them. And I do struggle with the term about treating everyone the same. You can't treat everyone the same, okay, because everyone is different.
Oh, yes, I definitely agree. Sorry, that's what I was going to say, was in terms of we have to adapt how we care. Thank you for correcting me. We have to be wary of how we adapt our care, in terms of cultural competence, sexual gender competence, all of that. Even, it sounds like a lot, but it's really not that. It's just adding in a little bit extra, like a perfect cup of tea. You just need a little bit of that, a little bit of this, and it's catered to somebody's needs. So I think that's what I was trying to verbalize better, to be aware of ourselves so that we are able to better care for each individual as and when they need it and how they need it, listening to them, empathizing with them. And even if you may say, oh, I didn't go through this, but tell me how it affected you so I know what to do better for the next time round. That alone, that acknowledgement alone does so much more for how the woman may how the people we are caring for feels, and in terms of being inclusive as well in our care.
Yeah, thank you. That's really good that you shared that with us. So thank you very much for that.
Thank you.
I'm just going through the chat. Do you have time? It's 11:30 now, Amber. So I guess we're running out of time for questions.
We can have a few more questions if there are some.
Okay. And I'm just going through the chat as well. So there's some comments in the chat really around intersectionality, and just being aware, if anyone's not familiar with the term intersectionality, is obviously about recognizing that everyone has their own unique experiences of discrimination and oppression, and we must consider everything and anything that we can not to marginalize people, okay, because obviously it's very subjective, racism and discrimination. And I think that's one thing I wanted to highlight here today.
Thank you, Sarah, so much for taking the time to speak to us today. I think everyone really enjoyed what you had to say and learned something from your presentation.
Lovely. Thank you. Thank you for having me.
You're welcome. Okay. I'm sorry, Sarah, can you just make me a host again? Is that okay?
Okay.
So now we're going to take a 15-minute comfort break, and if we could all come back at 11:45 to continue this conversation. Thank you so much. a doctor. Hi everyone. So we'll start the session again, and we'll now be discussing what is bias. Bias. Inclination or prejudice for or against one person or group, especially in a way considered to be unfair. Sorry, can we just mute ourselves, please? Thank you. How are biases formed? Conditioning from external sources such as family, schools, religion, the government, and the media. Or they can be formed by personal experiences with one's race, ethnicity, gender, or other external factors. There are two types of bias: explicit or conscious bias. This is when one person is very clear about their feelings and attitudes, and related behaviors are conducted with intent, processed neurologically at a conscious level as declarative, semantic memory, and in words. In its extreme, it is characterized by overt negative behavior that can be expressed through physical and verbal harassment or through more subtle means such as exclusion. The other kind is an implicit or unconscious bias. Operates outside of the person's awareness, can be direct, in a direct contradiction to a person's espoused beliefs or values, automatically seeps into a person's affect or behavior and is outside of the full awareness of that person, which is why it makes it so dangerous. It can interfere with clinical assessment, decision-making, and provider-patient relationships, such that the health goals that the provider and patient are seeking are compromised. So what does bias mean to all of you? Have you experienced bias in life, in work, at uni? Femis?
Yeah, I've absolutely experienced bias. I am a fat woman, and I can usually pretty much tell what people are thinking the second they meet me. If they've never met me before, if I'm going for job interviews, etc., and they've only ever spoken to me on the phone, there is, first of all, there's a look of shock on their face. They didn't expect a fat woman showing up. Then they try to hide the look on their face.
Yeah.
And then you have the other things that, like the microaggressions that slip out, that things like the most memorable one is actually when I was 18. I'd spent a great deal of time saving a particular manager, and saving himself from his mistakes. And he came to me on his last day and said, I just wanted to say thank you, because before I met you, I thought all fat people were stupid.
Oh, wow.
And I was just like, and you think that's a compliment, do you?
Hmm.
And he's like, well, yeah, you're really clever. I'm like, yeah, but you think that all fat people are stupid. I'm like, you're the stupid one here, mate. Seriously. I mean, and then he got really, really self-defensive, and oh my God, it was just awful. But yeah, I experience that kind of bias on a daily basis. Yeah, absolutely, Fatima, absolutely. And I mean, I mean, I've always been bigger, but I had a really bad accident. I fell off my horse. And while I was recovering from that, I put on about 10 stone. And I've not been able to lose it, because the damage that I've had to my body is quite extensive. It's taken a long time, a lot of surgeries, and a lot of physio as well to actually get myself to the point where I'm even walking again, you know, let alone considering a career in midwifery. You know, I'm going in and I'm terrified, if I'm honest with you. I am terrified. I am terrified of being othered, like I have been all of my life in midwifery. So it's different, but it's the same, if that makes sense. And people do have a bias about fat people. They do. Even if they say they don't, they absolutely do.
Yeah. So what I think we can take from
a lot of
sorry, continue.
Oh, so you go on.
What we can take from your experience of bias is that the feelings that you feel don't just last with you in that moment. It's a continuous.
Absolutely, it is continuous, and I am continuously thinking, okay, what will make me look the most professional and my slimmest? It's like not what am I most comfortable in. You know, I will wear a corset, a really, really tight one, underneath my clothing when I'm going to a job interview to make myself that tiny little bit slimmer. So people think, oh, well, at least she's got some shape rather than just being a blob. Because I've heard people say that.
Yeah.
As I've walked away, God, what a blob.
Well, that's really disgusting.
It is disgusting. And it's something that I'm incredibly fearful about. But I'm working. So thank you for letting me share that.
No worries, and please do get in touch. I'd like to talk to you more about this. We'll go into detail when we talk.
Yes.
Okay. Fatima, you had your hand up.
Yes, I did. So my full name is Fatima Bascucci. And I'm just going to turn my video on just for just to show what people don't expect.
Okay.
Hi everybody.
Hi Fatima.
I'm white. I'm North African, of North African descent. I have curly hair, but people say, oh, your hair's not that curly. And I always have to ask, what did you expect? I did actually turn up once to a shift at a hospital. It was my first time there on bank as a healthcare. And they said, oh, you're not who we were expecting. And I sort of laughed and I went, oh yeah, because I don't have a brown face or wear a headscarf, it's fine. I get that, you know, I get that all the time. And they all burst out laughing, which was good. But no, apparently kind of stuck my foot in it a little bit. There had actually been somebody who worked there before called Fatima, and they thought it was her coming back. So, but I do actually get a lot of people not expecting me to look like this. I did have a mentor at university who, when we met up, to be fair though, her name was, we all call her Kim now, but she's got a name that sounds like she said, well, because I've not got a blue rinse, I'm not older and I don't have a blue rinse. But she said to me, if you don't mind me saying, you don't look like a Fatima. And I said, it's okay, you don't look like I can't remember her name now, but because I just call her Kim, I've got used to calling her Kim. But yeah, so from my experience working with women, sometimes I've said my name's Fatima, and you see the confusion in the face. Some of them are welcoming, for some it doesn't make much difference. I live in Manchester, so pretty cosmopolitan city. But for one woman, I did feel once that her facial expressions kind of fell a little bit, so that was quite hurtful. But this is my experience of bias.
Yeah, well, I'm sorry that you've been through some of these experiences.
Honestly, looking at the grand scheme of things, it's absolutely nowhere near as bad as what I'm sure, you know, my Black colleagues would receive. It's absolutely not a patch on it. And I do feel that I do have the benefit of being able to feel like, because I look white, British, people just kind of like let me in and don't say much. But then sometimes if there are any discrimination, if they do have any sort of discriminatory sort of feelings, they mention it, and it kind of gives me the opportunity to say, actually, no, hold on. So in a way, I'm seeing it as a blessing, because it allows me to sort of sneak in and set a lot of people correctly as well, and just sort of say, well, actually, no, that's not the way it is. I've had almost a bit of prejudice from both sides, because sometimes I proudly say I'm North African, I'm Moroccan, and some people say, oh, you speak Arabic, you're an Arab. I say, I'm actually not an Arab, I'm from the original North African Berbers. So, but again, I mean, I have to sort of play with it in different ways and just kind of say, look, I'm as African as everybody else, I'm proud of it. And just because what you see, just because of what you see, that doesn't mean I fit in any kind of a box. It throws a lot of people, but like I said, I'm kind of proud that it gives me the opportunity to then stand up for, you know, Muslims, Africans, Black people in general, Asians, because I'm Muslim, obviously, and I've had a lot of Asian friends. So it gives me that kind of ability to sort of sneak in under the radar and then kind of, So, but anyway, just wanted to share, that's my kind of, that's my experience of bias.
Thank you, Fatima. And just going back to the hair comments, as you can probably see, I have curly hair.
Yeah.
And a lot of white people are always amazed at Black people's hair. I'm not quite sure why. And I just want to touch on this quickly, because it's not really the point of the conversation.
Yeah.
But it's okay to compliment someone's hair and to admire it, but please do not touch it. Okay. And yeah, that's my point about hair today.
I've got your back.
Jane, you have you want to share something?
Yeah, I was just going to say that bias for me personally has been around age. So when I've been in previous jobs, I didn't necessarily realise that it was as much of an issue until a couple of years down the line, where some of my colleagues who were a couple of generations older than me sort of said, oh, well, you know, I wasn't sure of you at first, and sort of said that they were doubting my ability to do the job when I first started, because I was about 20 or 21 when I started in that role. But I had to sort of, I reflected on it, and I realised that I had to sort of work harder to sort of prove myself, that just because I was going into the job young, that I was just as capable of anybody else was. So it was having to sort of go above and beyond, really, to sort of prove that I could do a good job even if I was young. So that was the bias that I'd personally faced.
So there really is different kinds of bias that can be portrayed, isn't there? And how does that make you feel now, to know that you did achieve what you wanted to achieve, despite having all those people thinking those kind of things about you?
Yeah, it makes me feel really proud of myself now. And now that I'm sort of nearly in my 30s and things, it's made me much more aware of it. And there's been, you know, on social media groups and stuff of like aspiring midwives saying, oh, well, I'm this age, whether it's somebody in their 40s or somebody that's just leaving school age, and sort of doubting themselves and their ability to do the job because of their age. And is it too soon for me? Is it too late and stuff? So it's just made me definitely reflect and realise that actually it's the qualities of a person and what they can bring to that job. So it's made me much more aware of that. So if anybody sort of says, oh, well, I'm going to be 40 something when I start my training, or I'm only 18 as they refer to it and stuff, just I make sure that I try and sort of reassure people in that position and just say you can still be a brilliant midwife regardless of how old or young you want to class yourself as. So yeah, I think it has definitely caused me to reflect on that quite a lot, really, and just realise that age doesn't really mean anything in that situation.
I agree. Well done you. Kat Young has written in the chat, I currently live in Spain, and Black, brown pregnant mothers are definitely treated differently here. I was pregnant at the same time as my friend, who's from Pakistan. They were both a similar age, and she was pressured into procedures that I wasn't even asked about. Sorry, just lost the message there. It was like they were using her as an experiment, sickening behavior. Well, this is something that's quite common, I think. Not really gaining consent from women of colour for certain procedures and not providing them with the risks and the benefits. So thank you for sharing that. Layla, do you have something you want to share? Oh, you're muted. Layla? Okay, we'll come back to you. Tizian?
Oh, I'm here.
Oh, hi, Layla.
Hi, sorry.
Okay.
Yeah, I'm originally from Somalia, and that means I am Black and a Muslim. I've experienced bias ever since I came to this country in 2003. Places, whenever you go, you just can tell from people's facial expressions when they look at you and they think, oh, she doesn't know, probably she doesn't even speak English. And you can tell from their facial expression, it just goes down. And when you start speaking and you're smiling and you know English and you can see them, oh, wow, okay. So they start speaking to you properly, which is very, very sad. And I've heard that from so many Muslim women saying the same thing, because the ones who wear the hijab, they also have experienced the same thing, even in the buses, when you sit in a bus. Sorry.
It's okay, take your time.
People come in, sorry. People will come in, and it's not just me who's speaking. So many women have said the same thing. People will come in and they want to sit, but then when they look at you, they just like, no, I'm not gonna sit there. You know. So just imagine that I will be starting university in September, and that is one of my worries, that I'm Black and I'm Muslim, and I'm so scared that, you know, people will, you know, look at me and think, oh, okay, here we go. You know, straight away, you know, when they look at a Muslim woman wearing the hijab, they think you're this, you're that, you're that. They have all this story behind you before they even speak to you. As one other thing I wanted to touch on just a little bit about, you know, the whole topic about inequalities in maternity. One thing I've realized during, because I've got 5 children, and now I have so many white friends, and they've told me about, you know, their pregnancies and what they, you know, the midwives tell them and what they offer them. And I feel like so many midwives don't offer us Black people like the white person. Like, for instance, you know, I came to realize about birth center after my 3rd
Oh, really?
child, and I'm thinking nobody offered me that. You know, I offered me, oh, this is what we got this and we've got that. Even just a home birth. Home birth was something I thought maybe us, we don't, that's why mostly us Africans, because I feel like probably if you're Black and you're born here, it's a little bit different, because, you know, you've gone to school, you've had the education, maybe you understand things more. But for us as Africans who come in this country, you go to a midwife and they just tell you these things and you're like, okay, but then afterwards you come to realize nobody told me this or told me that, or just even told me you can even have a home birth. You know, I would have loved to have a home birth. You know, I've got 5 children. It's hard for me to go to be in a hospital. All my pregnancies were, you know, okay, like I was low risk all my pregnancies. And I remember the first time when I went to the birth center and I had my baby, and the experience was so beautiful. Like, I could not believe that I did not have that all with my other children, you know. So there's a lot definitely, and I can't wait to get into the profession and just, you know, do something about it. Yeah, that's all I wanted to say. Thank you so much for the event. Thank you.
You're welcome. Thank you for sharing, Leila. Which
All right.
university are you going to?
I'll be going to King's College, yeah.
Okay.
King's College University, yeah, which is very good because they I don't know if they've always had this, but I think since the Black Lives Matter, I think they took deprived like postcodes within around London, you know, and they lowered the grades for them, the entry requirements for them. Yeah. So yeah.
I've sent you a direct message, so just keep an eye out for that in the chat, okay?
All right. Thank you.
Thank you, Leila.
Thank you.
Tizian?
It's pronounced Tashawn, but don't worry.
Oh, I'm sorry, Tashawn.
Honestly, it's fine. I just wanted to explain a little bit of my experience from service users. I've had care outright refused because I'm not white by some women. I've had microaggression comments. I was asked if I just wear lots of fake tan as a mixed-race midwife, and you know, I said no, this is just my natural skin color, and it was just surprising to me because Liverpool is, you know, where I live, it is quite diverse, not as much as the Midlands and down south, but the ignorance of some women that are still coming through in this day and age, and comments around name particularly, saying, you know, you're not white, your name must be Shaniqua. Well, no, actually, no, not at all. And the response of one of my colleagues to that was, oh, it's okay, you can call her whatever you want. You can call her that midwife from over the water. At the time, I was working in Wirral, which is a predominantly white area. But there was no solidarity from my colleagues to say, no, you know, call her name, and you know, reinforcing that. And on the flip side, as a service user, I've had people assume I can't speak English because also my surname isn't the most British, and they actually assume I'm Polish. I'm not. I don't have any Polish in me. My nan eloped, but that's another story. And what they really are asking is, you know, do you need help with your language? Do you need an interpreter? But without even coming to speak first. And I think that that's something that happens across the board. I know from sessions that we held as part of the Black Mum Magic project I ran up north in last summer. It was a series of listening sessions for Black and ethnic minority women to tell us about their maternity care experiences, and a woman explained how she, you know, an assumption was made about her ethnic origin and the language she spoke, and even so much as organising a TB injection for her child when actually she wasn't eligible for it. They just kind of ran off with this plan based on looking at her without actually finding where she's from, and it happens a lot. Yeah,
that's really bad. That's really bad. And it's really unfortunate that your colleagues didn't stick up for you and, you know, correct what was going on. I'm really sorry you had to deal with that. I hope that now you're in a better work environment and you don't have to face these kinds of issues. Does anyone else have anything they would want to share? Have you experienced bias, or do you have anything else to add? There are lots of comments sympathizing with Leila, so I think that's great. You know, we all need to support and uplift each other. So I hope, Leila, you find comfort in some of the comments that people are leaving you.
I just wanted to add, it's Liz from BCU. I actually got bullied at university by my fellow student midwives who tried to get me kicked off my midwifery course. So just to say on here, you know, just be supportive of each other, because I found it really difficult and I nearly gave up midwifery and came home because someone was so, you know, 2 people on my course were so vile to me. And I'd gone to my tutors telling lies. And even though I'd spoke to the other members of my group, none of them actually believed me. So it was really difficult when I was at university. So just be supportive of each other is, you know, is my advice from me. Regardless of your ethnic background, I am white and I was bullied by white people. So, you know, just make sure you support each other through your studies, because that's really, really important.
I agree. Thank you, Liz, for sharing that. I think bullying is an issue in the NHS, especially maybe in maternity services. So we all need to be aware of how we treat people and how we talk to people, and be mindful that everyone is probably battling a battle that we don't really know about. Does anyone have anything else they want to share?
Hi, Amber.
Hiya.
Hi. Hello. My name is Bella. I'm a student midwife at South Bank Uni. I wanted to just add one, which I know is not necessarily something that, you know, you can become quite like tolerant to hearing it, but one that I've heard quite a lot from women, especially, as, oh, you know, you don't have any children of your own. How can you understand like what I'm going through? And like, I know there are lots of students at South Bank who are 18 or 19 years old when they start the course. Sorry, I'm losing my voice. And so I think that's another thing, just to be like tolerant of and aware in practice, like especially for those midwives who are maybe a bit older or they've had children of their own, that sometimes it can be something that some people are a bit sensitive of, and not everyone does want to have children or is able to. And so maybe not to just assume that it just because you're in maternity that you want to have children yourself.
I agree. Often when I say to someone, oh, I'm studying midwifery, the next question is, oh, do you have children? And no, I don't. I think it's true. You should be
and people say that, oh, well, you'd be so good, you'd be perfect because you've got all of the experience.
Yeah, but actually there's a big difference between being a midwife and being a mum. I'm sure all the mums out there can relate.
Yeah, exactly.
But I agree. People need to be sensitive about asking these kinds of questions, even if you're not in working in maternity services, because you don't know what kind of fertility struggles people are dealing with. And to be quite honest, it's okay not to want kids as well. And I think that's a bit of a taboo, but I think people should just accept that kids aren't for everyone.
Yeah. And thank you to everyone for sharing your experience as well. I'm finding it really insightful. So thank you.
I'm glad. Thank you. Does anyone else have anything they would like to share?
Hiya, it's me again.
Hiya.
Hiya. I remember HSW, an MSW, sorry, asked me, oh, how did you get onto your course? I was like, I interviewed like everybody else. She's like, no, that's not what I mean. It's the way you sound. And I was like,
what do you mean by that?
So because of my accent, you know, I wasn't born in the UK. I was born in Nigeria. I came over here when I was 3, so my accent is a little bit of everything. But I was mainly raised in you know, inner city South London. I'm literally 10 minutes away from London South Bank. So I speak quite, you know, colloquial, urban, if that's what they want to call it. And then she was like, no, it's because, well, you know, because your university usually brings in white, you know, middle class white girls. So how did you get onto the course? Because you don't sound like everybody else. So there was already that othering.
Yes.
This was another black, and this was a, you know, a black colleague asking me that. She's like, yeah, because usually people who speak like you go to Wolverhampton. So,
okay.
I was just like, well, I'm here, innit? So, you know, you
tell her Laura, you're here and you're not going anywhere.
Yeah, I mean, I've had difficulties with the, you know, with this degree. Literally at the end, I wanted to give up last week and just say, you know, I can't be bothered, I'm not doing it anymore. Why would I want to be in a job that doesn't care about me? But it's the bigger picture. But
but sometimes when you're in the moment, you can't really be bothered to think about the bigger picture. So I totally get it.
Yeah. So I was asked, and they were just like, oh, you just like, you don't speak like everybody else. So it's always like, okay. So then you start to overthink, like, maybe I shouldn't speak like this, and you're constantly question how you speak, how you talk. You don't want to be taken the wrong way. Don't speak too local, because they will say that you're speaking intimidating and aggressive, and they don't understand you, etc., etc., etc. So there's so many layers to, especially as a Black woman, how to come across without being, you know, scary, which we're not, you know, properly, which doesn't make sense because my English is quite fine, but I'm multilingual as well. So it's just a lot of things. Yeah, well, I'll just say that.
I agree. I think we need to stop stereotyping completely, and Black women aren't angry or aggressive. So everyone just needs to drop that stereotype out completely.
Yeah. Thank you.
You're welcome. Thank you for sharing. Would anyone else like to share?
Hello.
Hiya.
Hiya. Can you guys hear me?
Yes.
Hiya. So my name's Yvonne. I'm a first year student midwife at the University of Hertfordshire, and I just wanted to talk about, you know, some things that I've seen and kind of experienced myself briefly. So I don't know if you guys can see, but my first name is Exorcy and then my second's Yvonne. It's actually wrong. My first name is meant to be Yvonne, but you know, things went wrong with my birth certificate. And something I've realized a lot of the times is, for example, when I go to placement and people try to pronounce my name and I correct them, of course I go by Yvonne, so I tell them, oh, this is how you pronounce my first name, but I go by Yvonne. And it's always kind of like a sigh of relief, like, oh, you know, thankfully I don't have to say that name, I don't have to pronounce that. And I just think to myself, you know, but what if I did go by that name? What was going to happen? What were they going to call me? The student? And it just confuses me all the time. There's a lot of people that they won't even try to pronounce it. It's just, I'm not going to call you by your name. Can I call you this? And I don't know, it's just really disheartening at times, because I can imagine there's so many of us from different backgrounds with cultural names with different meanings. And it's like, you know, why is it so difficult to try or, you know, to pronounce these names? Also, where I'm at placement, it is in a predominantly white area. And I've seen that a lot of the times there's very few Black midwives and doctors, but there are quite a lot of Asians. And a lot of the time, the women will refer to the doctors and the midwives, oh, you know, the Asian midwife, or not, pardon me, like the Indian midwife, the Pakistani midwife, bearing in mind that midwife or doctor has not once said that they are Indian or Pakistani. You can just see that they maybe are from a certain part of Asia. And not once have I ever seen a midwife or anyone correct them and say, you know, say the doctor's name. It's just like, to me, it's shocking, because I would hate it if someone said the Black midwife and not, you know, try. Obviously not everyone's going to know your name, but not once has a midwife tried to correct them or say anything. And I just find that shocking, because to me it's like, you know, are they not going to say anything? But I guess to them it's just, I don't know, it's just normal. So I just wanted to share a bit of my experience while on placement.
Thank you, Yvonne. And you know what, I've actually heard some stories about University of Hertfordshire and placements. So if there's any lecturers here from University of Hertfordshire, please listen to your students, because to not listen and to dismiss your basically saying it's okay for these kind of experiences to happen, and it's not okay.
100% agree.
Thank you for sharing.
Thank you very much.
You're welcome. Would anyone else like to share?
Hi, Amber.
Hi, Alice.
Jasmine.
Sorry.
Sorry, I've got a sick child at home, so sorry. It's not. Sorry. The experience that I was going to say that I've had in placement, in the short time that I've been in placement, and it was I was working with a midwife who was supporting a lady, and once she had given birth and everything, so the lady was Asian. I'm not too sure which part of Asia she was from, and you know, understandably she wanted you know, food, and you know, the midwife was like, oh, what food would you like? And automatically she went, like, the lady was asking for, like, I think she wanted like fish and chips and whatnot, but she kind of automatically went to the curry side, and I was like, you know, she, you know, automatically kind of had those biases that, you know, because she's Asian, straight away that she wants Asian food maybe. And I just thought that, you know, the woman has just told you that she wants fish and chips or whatever else is there in the fridge, and you've gone and you're trying to put your biases and telling her that, you know, that there's curry or whatever kind of thing, and that's not what she wanted.
Yeah.
And yeah, that's just my little observation.
Jasmine, was that the midwife or was that?
That was the midwife. So the midwife was a white English lady, and yeah, the birthing woman was an Asian lady that you can tell that she was born and bred here kind of thing. But you know, she had her husband and her mum. You know that. You know, they're speaking their language and stuff like that. So I think she just made an assumption that she doesn't want traditional English food, and she might want her own food or something like that.
Okay. Thank you for sharing, but before I don't go just yet. When you see these little microaggressions, I know it's daunting because the midwife is your supervisor, but you need to address it. You can address it away from the client, and then at a time where you feel like you're ready to talk about it, but definitely address it. Because when I was in community, I had a lady, she was Sri Lankan, and she couldn't speak English well, so she actually requested a translator from Language Line. And the midwife I was working with told her she didn't need it. So I was actually quite shocked the whole time that she was in the room. And I should have said something at that time, but I addressed it once the client left. And I said, why did you not think it was necessary to have a Language Line help us? And the midwife just said, oh, she could understand fine. It's not for us to judge if they can understand fine, especially when they're actively asking for a translator. So I know it's difficult as students sometimes to raise a concern or to address an issue, but please, let's all try and use our voices as best as we can. And if you don't feel comfortable doing it yourself, please talk to your CPFs and they can help you. And if they don't help you, you can talk to your link lecturers or your cohort leads. I'm sure they'll be more than happy to help. Alternatively, if you're still not getting any help, please message me or email me and I can help you address it.
Yeah, that's definitely a learning curve that next time, I mean, I don't know if it is appropriate to still raise it, like directly talk to her, but I know for certain if that was to happen again, you know, not in front of the lady, but, you know, once we step out to kind of, you know, talk about him and, you know, to see what she kind of, for her to be able to see what she said and if she felt that was appropriate to do that.
Exactly. It's always a learning curve. Don't worry about it.
Yeah.
Thank you for sharing, Jasmine. Alice, you have your hand up.
Yes, I do. Hello.
Hiya.
So I did write on the chat earlier. I am a qualified midwife. I'm in a same-sex marriage, and my wife is Black. I am a white woman. Often people feel very comfortable around me to be overtly or covertly racist or homophobic because they don't expect me A, to be in a relationship with a woman, and B, to be in a relationship with a Black woman. And because I'm white, they feel very comfortable to sort of say these things around me. I do work now in a predominantly white area. We do have a lot of Black agency midwives who work at my hospital, and often I will find my other colleagues talking about they and them, and it's the same language that you hear all the time: rude, aggressive, loud, and it's all these sort of negative connotations that you never hear them saying about the white midwives, that they that they don't have, that they don't like, shall we say. So I do often pick it up and I say it, and I say, well, why why are you saying that? It is very, very difficult, and it's really exhausting as a white woman to feel like you're constantly correcting people and standing up and saying it. So I can't even imagine what it must be like as a black student midwife, a black woman who has experienced this their whole life, to have to be the ones who are expected to speak out about it. And I think that it is time to change. It's time for more white people to speak out. It's time for us to be anti-racist. And it's time for us to understand our privilege as white people. So I just sort of wanted to add that in. I mean, I've got a whole lot of stories, but it's absolutely not the time. It's not about me. We're talking about racial bias, and I think it's really, really important to sort of say that for my white colleagues more than anything.
Thank you, Alice, for sharing, and thank you for using your voice. Don't stop, we need you. And I encourage everyone to be like Alice. It might feel uncomfortable, but imagine how uncomfortable it feels for someone experiencing bias or racism or prejudice. Keep using your voice, call it out, don't let people get away with it.
I will. Thank you.
Thank you, Alice. Would anyone else like to share? Okay, so we'll go on to the next slide. Why is stereotyping dangerous? What is stereotyping? A widely held but fixed and oversimplified image or idea of a particular type of person or thing. Examples of stereotyping. Asian women act like princesses. Black women have tougher skin and a higher pain threshold. Women who don't speak English or is not their first language are less intelligent. These, of course, are not true. Why is stereotyping dangerous? It causes assumptions resulting in the client not being treated as an individual. It can lead to medical negligence. It can cause negative outcomes for women and their babies. And it can create a lack of trust between clients and their healthcare provider. Florida-based midwife Jenny Joseph has said, simply by improving standards of care, mortality rates can be dramatically improved. It is not groups of people that are different, but how those groups are treated. It is racism that kills, not race. So, opening the floor to have a conversation again. What kind of stereotyping have you witnessed, or have you been brought up to think is true when really it's not true? This is an open, honest conversation for us to all learn, so please don't be shy.
Hi.
Hiya.
My name's Tosin, or Tosin, either way. So first off, I'm a first student midwife from the University of Hertfordshire, and I'm on the 18-month course. So I'm tall and I'm a black girl, obviously, and I guess I find people often ask me like if I play basketball. Like it's kind of obviously it's stereotypical because obviously there are a lot of black female basketball players, and I'm actually really bad at basketball. It never really offends me, like I take it quite lightly. I'm just like, no, I don't. Like, if anything, I'm more into like sprinting, athletics, running. Those are the kind of things I was better at. But it was just a common thing. I know that people stereotype like black people as being really good at all sports, which isn't obviously the case. So just wanted to, throw that in there.
Thank you for sharing, Tosin, and I agree. It is a stereotype and a generalization. And even though it might not be as harsh as some of the other stereotypes we're privy to, it's still a stereotype and it is still racist. So thank you for sharing. Does anyone else want to share an experience of stereotyping or discuss something around stereotyping? Sharon?
Hi. Yeah, I'm actually a privileged white woman, so you know this doesn't happen to me too often. But I'm also an independent midwife, and I work in the NHS at times, and
Yes.
that often involves overcoming, I think, stereotypes about what independent midwives are and how we act.
Mhm.
And you know, just for example, there seems to be a bit of an assumption that independent midwives push women into going off guideline or off pathway or doing unusual things, when actually we're kind of here because some women want to do things that are off guideline or off pathway or seen as unusual and seek us out to support that because we're very attached to supporting individualized choice.
Mhm.
And I feel like, yeah, when I have a new conversation, and so often with other midwifery or you know, doctor colleagues, we have to get over that hurdle first, that I'm not how they see me, and in fact neither are my other IM colleagues either. Yeah, so just thought I'd flag up that one.
Thank you. So yeah, don't discriminate against independent midwives either. They work just as hard as everyone else. We're all part of a multidisciplinary team. Let's not forget that. Janaina.
Hi everyone. Sorry, I'm having problems with my camera and I'm trying to put it on, but it's not working. Can you hear me?
Yes.
My name is Janaina. I'm a student midwife from London South Bank. I'm a first-year student midwife, and I would like to share my experience about stereotyping. And as you can know here, I'm not English. English is not my first language, so that is one of the type of stereotyping that I experienced in the past.
Mm-hmm.
Because people assume that because English is not your first language or because you have an accent, you're not intelligent.
Yeah.
Or not intelligent enough. And it's really hurtful and basically really dangerous because they make assumptions about a person even without knowing them.
Mm-hmm.
And well, I just would like to say that is one of them. I'm a mature student as well. I'm a woman of color. I wish I could put my video on so you could see me. And so I experienced a few of them. And and one thing I heard about midwifery before starting is that you need to have a thick skin to be a midwife. And
resilient, isn't it?
Yeah. And I actually don't like that. Why we are all human, you know. I'm very sensitive. I cry a lot. I have a big heart, and I think that makes me a brilliant midwife, makes me to understand people, make me to understand women. I also speak 3 other languages rather than English, and I consider myself intelligent. So I think that's really dangerous. It's a really dangerous assumption to make, and really hurtful. So I just would like to share that with you.
Thank you, Janaina, and I can confirm that you are intelligent and you're going to be a fantastic midwife.
Thank you, Amba.
Yvonne, you have your hand up. Do you want to share something else?
I just wanted to talk about an experience I had at placement as well, actually. So as I explained before, where I am is predominantly white, so we don't get many Black or Asian women, but we do have a few come in. And I'll never forget, this was literally my first ever placement, and I was on recovery with my midwife, and there was a Black woman there, and she was so happy to see me. And, you know, I kept having to remind her, because she wanted me to help her with a lot of things. And I had to remind her that there's some things I can't do because I'm a first year student. And she literally did not want me to leave her due to the bad experience she had on the labor ward. Mm-hmm. So she was on recovery and she was having problems and she was in a lot of pain. So she was asking for a lot of assistance with her son, her newborn son, and within herself. And then I helped her through what I could. And I just remember my next shift, she was on the board up in postnatal ward. And I just remember some of the midwives saying, oh yeah, no, we had to get rid of her. She was just making too much noise. She was complaining about all sorts of pain. And they were basically trying to say that she was lying and that she couldn't have been in that much pain. It's not that, you know, it can't be that painful. Why is she screaming so much? And you know, I did want to say something, but like I said, this is my first very placement, and you know, and I never did see that midwife again, but that really stuck with me because it was like, I've seen so many other white women in recovery doing the exact same thing, nothing ever. But why is it when it was the Black woman, she's doing a lot, you know, it can't be that painful? Why is she, you know, asking for so much assistance? I was just, it was just really shocking.
It is really shocking, and it's I know there's the feeling you want to say something, but you don't know how to navigate it. You're new, you're getting used to placement, and obviously we don't have the same knowledge as the qualified midwives, so it is quite scary sometimes. So I understand why you did say something, but just remember the feeling you had during that time, and if you see something similar to you, to other clients or to other staff members, just try and support them and speak up if you're comfortable to. And like I said to Jasmine, if you're not comfortable speaking up for yourself, go to your university, talk to your link lecturer, your CPF, a different lecturer. If you have a better rapport with them, someone will help you. And if you aren't getting anywhere, just let me know and I can help you.
Okay, thank you very much.
You're welcome. Okay. Kate?
Yes, thank you. I am a doula in Germany, and I pretty much wanted to become a doula because of how the opportunity to empower people, to be an advocate, and especially for like this impact to this like potential to impact inequities in maternal health. And I think that there's a big stereotype here in Germany, and I don't know how it is in the UK, about doulas trying to pretend to be midwives or steal a midwife's job or something like that. And yeah, I just think that it's a really big shame, especially because the potential that doulas do have. And actually in my city here, which is supposedly the wealthiest city in the entire country, doulas, there's only one birth center and doulas are completely banned from it. And it's because of that reason that they think that doulas are trying to pretend to be midwives or working out of scope or whatever. And I think that this, yeah, I mean, it's just a huge disservice to people that benefit the most, arguably, from having a doula in the first place. So I think that's something interesting, which I've noticed. And I mean, especially when part of the job is to like help your clients advocate for themselves. I had one doula colleague who said that she was supporting a Black family and she had had this whole conversation with them about, okay, these are your rights when you're giving birth, and you can say no to this and you can say yes to this. And so the father of the child was there helping his wife, helping his partner advocate for something that she did not want, like some procedure that she was being manipulated into. And the midwife said, "We're going to call security, sir, like you're being so aggressive." And I mean, it's just like, it's a perfect example of how, yeah, I mean, health inequities in a lot of different realms here, I think.
Definitely. And thank you for joining from Germany. I think that's amazing, by the way. Doulas are very important, and I think they need to be more encouraged to clients in the UK to be able to advocate for the clients and really help them in the ways that they need. So and I have seen a lot of conversation on social media that doulas aren't respected by qualified midwives, and they're kind of shunned and asked to leave certain situations. So I'm going to personally look into that and really educate myself on why that might be, and talk to other doulas to really understand what you guys are going through in your careers. So thank you for sharing.
Hello.
Hiya.
Hi, I'm a doula, and I'm a Black doula as well. And I just wanted to raise another issue that often comes up and has been spoken about in other forums. But as a Black doula, supporting other people of colour, sometimes it comes up that when there's more than one person of colour in the room, that there's even more opportunity for discrimination and racism. And when there's already a stereotype around what doulas do and how they support clients, I think it can become a barrier as well for some people to have that support and worry that possibly having someone in the room that is of colour might actually be a hindrance rather than a help. And that can sometimes be a barrier for people of colour getting support, where they might see that actually as having someone who isn't of colour might actually help them more, which is a really scary and toxic place to think that people aren't choosing to get the support that they need because they're worried about what that person in the room might do for them. So it's just another consideration as well.
Thank you for sharing. I hope everyone takes that on board. In the chat, Karima has said, as a first-year student midwife working with a predominantly white demographic, I was asked on a postnatal ward by a huddle of white midwives and a housekeeper to go over to the South Asian woman whose mother had brought in a curry for her daughter to tell her the smell was making the other women in the bay feel sick and refrain from eating it. I'm a brown British mixed ethnicity student midwife with a Muslim name, and they told me I should go over because the women would listen to me, despite not being allocated to this woman's care, and it would be a less harsh, i.e. meaning racist, coming from me. I didn't go over, and I assume no one else did in the end, thankfully. The comments from staff were drenched with racism and within earshot of the woman. I didn't process it at the time or think to raise this with anyone as a new first year. I will be more courageous in the future. Thank you, Karima, for sharing. Yeah, it's like I've said before, it's very daunting being a student midwife in all different respects. So yeah, just going forward, please speak up for people if you need to. And also, if you're having these kinds of thoughts and feelings towards a woman of colour or someone of a certain religion, then you have to really ask yourself, is this the right career for me? Because we're supposed to provide unbiased, individualized care to clients, and the NMC code states that we shouldn't discriminate, and you know what the NMC code says. So if you feel like you have these thoughts and feelings towards women of colour, then you're not following the NMC code and you shouldn't be on the register. Personally, that's what I think. So let's see who else has hands up. Jane?
Hiya, yeah. I just wanted to say about things like stereotyping and stigma. As a woman who is significantly overweight, as far as the BMI classification goes, there was massive amounts of stereotyping when I was accessing maternity services to have my little boy. There was a lot of sort of stereotyping that because I was overweight, I must be unhealthy. Because I was overweight, I wouldn't be able to have my baby naturally without interventions needed. There was almost surprise every time I went to a consultant appointment. There was surprise that I hadn't developed gestational diabetes when I'd been checked for it, and when I had growth scans that my baby was growing normally at like a normal rate. And I think there was massive amounts of just sort of expecting me to be unhealthy because I was overweight. So I think that was quite a damaging thing to have faced, really. And I feel that things are very focused on BMI, and if your BMI is over a certain number, then there is a lot of stigma attached to you and how you access care as a result of it, really.
I agree. Thank you for sharing, Jane. I read on social media the other day that BMI is quite dangerous, and it wasn't actually invented anyway initially to be a measurement of health. So I think more conversation about the dangers of BMI needs to be had. And if a woman is presenting as a high risk due to their weight, or we need to be careful in how we treat them and how we talk to them. So thank you for sharing. Femis?
Yeah, I mean, just to follow on with what you said, Amber, about BMI. Yeah, when it was invented, it was actually created to assess the weight of the average weight of a population. And it's actually been said by the creator that this should not be used individually. This should only be used in groups of 500 plus.
Yes.
It is entirely inaccurate. It's entirely medically insufficient. And what actually happened was a lot of people, everyone went to bed in 1996, and then a couple of 100,000 people woke up as clinically obese, because that was what it happened in 1996, and the clinical guidelines for obesity came out, and it was literally then. I'm really, this is my thing. So yeah, I just really wanted to follow on with what you said about the BMI index. I have a real thing about the BMI, and I've actually changed my doctor's surgery thinking, because I had a massive row with one of the practice managers, and they were like, actually, what you're saying is right. You are right. They came back afterwards and said, Jess, you're right. I've investigated everything you've said. You are right. We're not going to use BMI where we possibly can. We're going to go by weight and individualized care. And I was like, but you should be doing that anyway.
Yes.
That should be what you're doing anyway. You shouldn't be basing it just on BMI. So I just wanted to follow up what you were saying. So thank you for bringing that up. Really appreciate it.
Thank you for your contributions. I appreciate it. Tishan?
Yeah, it was just to kind of back up this BMI notion as well, and just raise the issue that we should be looking at fat mass more as an indication of risk status in terms of preeclampsia and things that we can do to intervene more with nutrition and diet, and having those conversations. The care that we do at the moment, majority of women who fall into that moderate bracket, so may have a BMI of say 30 to 35, aren't even achieving the dietetic referrals that are put in the NICE guidelines that they should receive. So this is an area that I lead on for Cheshire and Merseyside, and my PhD at the moment is looking at diet-related health inequalities for the perinatal period. And one of the things that I'd be interested to look at is accessibility of food for ethnic minority communities as well. So just a comment to say, if anybody is interested or works in that area, please do get in touch as well.
That's amazing. Thank you so much. Sharon, you have your hand up. Is that a legacy hand?
No, I think I didn't take it down, sorry.
No, it's okay. Does anyone else have anything they would like to add?
I think sometimes people will actually go to quite extreme lengths to make a stereotype fit in their head. Just thinking of an example, my boyfriend, he's mixed race, and he recently started working for a company remotely. So he's never met any of the people who work for the company.
Okay.
And they were doing a sort of team building fun exercise where it was a kind of desert island discs type game. And the idea was to guess who had said these songs and guess who likes these things, basically was the point of the game. And the songs that the sort of mystery person had suggested were songs by like the Beatles or like Led Zeppelin, so quite old songs that you would assume somebody in their late 20s, which my boyfriend is, probably wouldn't be interested in, which is in itself an assumption, but there you go. And then the next question was about sport, and it said basketball, and they instantly all said, oh, that must be Ben. So they think it's more likely that he would listen to the Beatles and Led Zeppelin and songs that are sort of way before his time than not like basketball. They just couldn't imagine that anybody else might like basketball because he was the only black or brown person in the group.
Yeah.
And it was like there were other things as well in the conversation that just made it quite clear that it wasn't him, that it was an older person. And they literally just completely ignored all of those things just so that they could sort of satisfy the stereotype about basketball. And he's never played basketball. He has no interest in it. He also doesn't listen to Led Zeppelin. So it clearly wasn't him, but they just desperately wanted it to be him because of that stereotype.
I know, it's crazy. Some people just want us to all fit a certain narrative, and that's obviously not how it works, and it's not right at all. When I worked in a dentist before I became a student midwife, I worked in a private practice. It was very white dominant. Patients were white, staff were white. And it was a time where it was really hot in the summer. And one of the patients said to me, "Oh, you must be used to this kind of weather." And I know what he was getting at, but I said, "Sorry, I don't understand what you mean." And he was like, "Because you know where you come from." And I was just like, "I was born here, so I'm no more used to it than you are." And it's these kinds of comments and microaggressions that build up and build up, build up, build up, and can have a really detrimental effect on people of colour. So you might think you're saying something innocent and just trying to make conversation, but please be mindful of the comments that you're making. I have a comment in the chat from Rebecca. "Hi there, I'm a student midwife and I experienced an incident on the wards where what started off as an innocent conversation about whether I had a boyfriend ended in her expressing negative views on the fact that I, a white woman, had a black boyfriend. She proceeded to share with me her negative views on clients with interracial relationships. The point of me sharing is that when I went to speak to my CPF and link lecturer and received great support afterwards, which involved meeting with the nurse and expressing how she made me feel and why what she said was not appropriate. So to anyone to witness or experience situations they aren't happy with, the support is out there. Please do speak out." Thank you, Rebecca, for sharing. Yeah, please do speak out. I'm a biracial person. My mom's white, my dad is black, half English, half Jamaican. I have had people openly tell me that they don't think interracial relationships should happen, that biracial children are less likely to have their dad around. I've been called all sorts of names because I'm biracial. So yeah, this really needs to stop because it's just ridiculous and it's just out of control that people think that they can say these kind of remarks. And then when you call them out for being racist, all of a sudden they're not racist and they're the one that is offended. So yeah, thank you all for sharing your experiences and your comments. Is there anyone else that would like to add anything to the conversation? We're going to have lunch at 1 o'clock, so please share.
Hi Amber, it's Renee.
Hiya.
Hi, I'm Renee and I'm a second year student midwife at University.
And she's on my student panel, just FYI.
I think when it comes, I think everyone's been making really valid points today, and I'm just thinking about for placement and not making assumptions about people, because there's been many times when I've gone into placement and people have seen my uniform, and our uniform is quite distinct, and they just see my face and my skin colour and assume that I'm the cleaner. And this happens quite a lot, and they never ask or see the fact that I've blatantly got like my university written across my chest. They just don't see that. They just see the fact that I'm a black student or a black person, and then therefore I must be the cleaner. Mm-hmm. It's just not making assumptions and being fully aware and taking note on like who people are, and don't just see, oh, you see a skin color and that's it, that's your assumption, they must be the cleaner, they can't be anyone higher up, because in my placement there's people from every ethnicity in my placement, and I could have been a doctor, but you've assumed that I'm a cleaner and you've made me go and do something because you think I'm a domestic. And I think people just need to be more aware of who people are, and just be aware of your language, and like that people can be anyone, so just to be more aware.
I agree. Thank you for sharing, Renee. Anyone else? Let's have a look at the chat. Poppy has shared in the chat, "My partner is a Nigerian male working in a nursery, and he has experienced So much stereotyping. So many people think that he won't be caring or that he will be aggressive towards the children just because he is a Nigerian man. He is the most caring and kind person I have ever met. We are both athletes too, and people always assume he's a basketballer because he is black and that I don't do sports because I am a Pakistani woman. It just goes to show that stereotypes have no ground at all, and they're very offensive and very harmful. Femis?
Sorry, I just wanted to say that the way everybody has contributed here today has been one of the most affirming, traumatic, but also, I guess the word I think is exciting. I can see the future and where it's headed. And I can see that within this group of students and students to be and tutors and lecturers and midwives, all of you here, I can see that it's going to change. I can see that it is. There's the passion is there. And I just want to thank every single person who has contributed, because you've given me so much to think about and so much to write about and explore for myself, my own ingrained things. It's a constant learning process. So Thank you so much to every single person. I am so grateful to all of you. Beyond grateful. I really do feel like you're all preparing me for 2022 when I'll go to uni. I do foundation year in September, and I'll go to university in 22. And I feel like all of you are kind of like giving me prep, and I can't thank you enough for that. I really can't. So thank you for sharing your trauma. Thank you for sharing your hard stories, and just thank you for being you, and keep on fighting, because I'm not going to stop and I'm going to need all of you.
Thank you, Femis, for your positive feedback. I'm sure everyone agrees. We must keep fighting and using our voices to make things better for women of colour. We must bring down the statistics and erase these disparities in maternity services. That is the whole point of today. So now we'll break for lunch and we'll come back. If you could all come back for 2:10, ready for Mars Lord to speak to us at 2:15. I think that'll be a really great chat. So enjoy your break, walk around, rest your eyes from the computer and screen time, and I'll see you at 2:10. Thank you.
That label printer. That's a cool nick, isn't it? It's fixed now.
We can hear you.
Yeah.
Hi everyone, welcome back. We'll just wait for everyone to start joining and then we'll get going again. Fatima, a lovely lady called Fatima, has messaged me privately during lunch and she wanted me to share with you guys her experience, so I'll do that. She said, "Hi Amber, I'm not very confident to talk because of my accent and being bullied and harassed in the past. I'm scared to talk a lot of the time and I have lost my confidence. I want to say there is clearly a level of bias towards accent, dangerous stereotyping, and unfortunately there isn't any awareness around it within maternity services. From my experience, simply having an accent submits me to stereotypes. I have 2 academic degrees, a master's degree, but people make assumptions about me. Lack of intelligence and not appealing to or being trustworthy. People don't believe what I say and they don't trust me, but they believe it when it is said by a white person sitting in the same room as me. It's very exhausting to constantly justify myself, and it's had a very traumatic impact on Fatima. So I think we all need to keep thinking about how we talk to people and the kind of language we use. It's not acceptable to use stereotypes when assessing what kind of care someone needs. Everyone should be treated as an individual. Everyone should be respected. Everyone's privacy and dignity should be respected. And like I said earlier, if you feel like you're not capable of doing that, then unfortunately, you need to find a new profession. In 3 minutes, Mars Lord will be talking to us. So please make sure you are ready and comfortable to listen. Okay. I'm now happy to introduce Mars Lord, also known, as the Abuela doula.
Hi, thank you very much. Well said, Amber. I get lots of different pronunciations of the word abuela. Abuela is Spanish for grandmother, and it's one of my most favorite words for grandmother, particularly now that I actually am one. But my other favorite word is nonna, and that's who I am. So it's lovely to see you all, those of you that I can see. Let me have a little look, see if I can see some gorgeous faces. I see no faces. Oh, there's a face. Hey, Liz, good to see you. It's not just me and you, Anna and Michelle. Oh, thank goodness. For a minute there, I thought I was talking to myself. Lorraine, Kate, Themis. Okay, so I'm going to stop at this point, Jasmine and Madassa, because and Laura and Amika, because, okay, so now everyone's going to come in and turn on their cameras. And I don't think even I can manage to say 163 names before I manage to get through speaking with you all. I do love seeing you, and it's wonderful to know that I'm not talking into a void. I've done a couple of conferences where I've just spoken into a void, and that was when I realized my mother was right. I really can just talk to anybody about anything at any time in any situation. But, you know, mother of 5, I'm used to faces looking at me. Anyway, so let's see where we get to today. So I'm going to start by sharing my screen, and of course it's Zoom, and of course I'll do something that'll just be totally bonkers and stupid. But frankly, I've just had the 27th anniversary of my 27th birthday, so I don't really give a rat's. I think I'm fabulous. I know I look fabulous. So let's get this party started, shall we? So we'll go to share screen. And then we'll move that because that's totally in my way. And let's go to present mode, because I couldn't work out how to do present mode and share my screen at the same time. Okay, so here we are at the Racials, Inequality and Maternity Services Conference. And what I'm talking about more and more is how we all work together to bring reproductive justice. Because actually, we're no longer in crises. I mean, no, let me rephrase that. We remain in crises, but what's going on with Black maternal health has gone beyond crises. This is now scandalous because this has continued and continued to be perpetuated. So let's look at who I am. So I'm Mars Lord. Mars, like the planet, not like the chocolate. I'm not as sweet as some of you might like to think. Actually, I'm reasonably convinced there's a fair number of you that recognize I'm not sweet at all. I'm a birth activist, a reproductive justice warrior. I think when we think about birth activism, we think about probably marches and demands, etc. We think about people raising the conversation, and I'm here to do more than raise the conversation. I'm here to find out what it is that we can be doing. I'm also a life coach, which for me is like being a doula without the physical human baby at the end, walking alongside people in their journeys, looking at how they're thinking, why they're thinking those thoughts, what the results are of the actions that they take because of their thoughts and feelings. I'm also a doula trainer. I'm a doula trainer because when I first became a doula, anytime somebody else, Black or brown, became a doula and would ask, hey, where are the Black doulas? I was the one who was pointed at. I was the Black doula. And, you know, I mean, we saw is it Little Britain? We saw the Little Britain sketches about being the only gay in the village. I'm here to let you know I'm not the only Black in the village. And I'm also here to let you know that I do not want to be your Black friend. I'm an educator. I talk about cultural safety, cultural humility. I talk about social justice, racial justice. I talk about the world of birth. You can find me on the usuals, Twitter, Instagram, and Facebook. Not that I use Facebook too much. And actually, I don't really use Twitter hugely, but I do get there from time to time. Oops, too far. So, Abuela doulas. As I mentioned, Abuela is the Spanish word for grandmother. When I do my DNA, someone said to me one day, how can you use that? You're appropriating Spanish. I didn't mention to her that actually the word abuela comes from the language of the colonizer, and therefore it's a Spanish word, because I thought that was too deep to go into for her. But I like abuela because it's grandmother, and I found it in my DNA somewhere between the enslavement and raping of my ancestors. There's a bit of Spanish in there too. So we're called Abuela doulas because I believe in bringing the wisdom of the grandmothers into modern birth. And you were all about modern birth. I train birth doulas, I train postnatal doulas, I mentor them as well. So Abuela's Red Tent is joint work that I do with Nicola Mattia Goodall. And Mattia is a fabulous Muslim woman. And together we run cultural competency workshops. We also run workshops and courses on the racist roots of obstetrics and gynecology, which is a lot of the reason why we're having the things that we're having at the moment and seeing within Black and brown and marginalized or Western marginalized communities. And these roots are what lead us to the outcomes that we have right now. And we also run international doula courses. A quick, hey, let's play the fame game. I've been featured on Channel 4, BBC One, radio, blah, 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 and been on Gold Learning a few times. That's for the people that like to know about certificates and qualifications and what gives me the right, etc., etc., etc. And because I like to tell my kids that people do actually follow me on Instagram, etc., do feel free to post a story or something to let people know that here I am. Not just because they deserve to see such stunning beauty, but also because let's get this conversation out as far and as wide as we can. So forgive the blurry slide. I didn't quite manage to make that work the way I wanted. We all know, we all should know, or perhaps we have a passing knowledge of Embrace and the reports that have come out. Now, this is a good point at which to stop and let you know something which will tell you why I'm not named after the chocolate. We're going to look at anti-Blackness today and how that plays out in the racial inequalities and how that plays out in maternity. But I'm not here for white fragility, white discomfort, white saviorism, white centering. None of those things. I'm not here for the tears. Because Black women are dying. And if I've managed to sit in my discomfort for 54 plus years, then I think you can manage to sit in your discomfort through this short amount of time that I have with you. So when I first became a doula, some 16 and a half, almost 17 years ago, I discovered, like I'm sort of some explorer that went looking, but I became aware of the fact that if you were Black and you were birthing, you were twice as likely as your white counterparts to die within the perinatal period. Now, this is the point at which I remind people that, of course, maternal death, maternal mortality is low. And that's the point at which most people check out and say, well, if maternal mortality is low, then it's not that huge a number of Black people who are dying. So maybe it's just not that important. So at what level does it become important? Because then it went up to 3 times more likely. And then it went up to 4 times more likely. And we're now around the 5 times more likely mark. But Mars, it's not 5 times more likely, it's 4.35 times more likely. There's been a reduction. We have been really good and really clever and really wonderful. And we have reduced it. Actually, you kind of haven't. What's happened is there's been a reclassification of race. So how Black is Black, who counts as Black, who counts as brown, who counts as mixed heritage, who counts as white. Well, I'll tell you who counts as white, as Caucasian. Everyone whose ethnicity is unknown or unrecorded. You're taught to tick the Caucasian box. So when we say that Black women are, and I talk specifically about women because that's where the research has me. I'm not talking about trans and non-binary people because they're not the ones within this statistic. And Lord help us when we include them. Anyway, so we're currently at 4.35 plus, and I think actually it's probably higher than 5%, 5 times even now, because do remember that the Embrace report is a few years behind this very present day. So we see that there's been a jump from twice as likely to 5 times as likely the risk of death for Black women in the perinatal period. And according to the Embrace report, this is a non-significant reduction. Mars, I don't know what you mean. I mean, surely it's a great thing that when we now close the gap by 0.65%. It's funny because when some of you look in the areas in which you work, you say, well, we don't need to worry about cultural competency and cultural safety and cultural humility because that's only 3% of our population. So we're looking at these percentages, we're looking at these times more, but we're forgetting the individual people that make up the numbers. How many Black deaths are acceptable to you? How many brown deaths are acceptable to you? What's an acceptable number of a maternal mortality? Is it 1? Is it 10? Is it 100? Is it 10,000? So let's look at why they say that Black mums and their babies are dying. Well, there are 3 main reasons that are constantly trotted out. The first is eugenics. The second is, oops, too far. The second is socioeconomics. And the third is lack of education. What do you mean eugenics, Mars? How dare you talk about eugenics when we're here all about loving all of the people all of the time with all of our hearts, because we're doing this wonderful altruistic vocational work that doesn't pay a lot and basically knocks us around a bit. Well, eugenics is the belief that white bodies are superior to Black bodies. But nobody's saying that, Mars. Nobody's saying that eugenics is at play and this is why Black mums and their babies are dying, except they are. Because Black-bodied people are predisposed to diabetes, hypertension, cardiac issues. But we don't think about what took them to that place of predisposition, nor do we think about what we do if they present with these levels of predispositions. We simply look at the constellation of causes and we say, well, their bodies do this, their bodies do that, their bodies are weak here. I mean, one of the gurus of birth, Ina May Gaskin, was heard to say that if Black mums simply prayed more, went into their gardens and ate vegetables, they wouldn't die at such rates. There does come a time when we need to take a deep breath and pause as we look at our gurus and say, I'm loving your work, but this is problematic and this is why. So eugenics states that Black bodies aren't so great at giving birth. And what's really scary is talking to a senior midwife just a week or so ago who said, without thought, it was so natural, clearly part of the education, well, it's the African pelvises. So let me ask you this. If Black-bodied people are crap at giving birth, if Black bodies are inferior to white bodies, why then are we the global majority? So here in the UK, we're talking about Black, Asian, minority ethnic people. And as we say those words, we think they're just a few. And we bring them down, condense them down to what they look like here in the West, rather than recognizing that they are, in fact, the global majority. and hold on to your britches, but that white-bodied people are the global minority. So the second reason that we give for why Black mums and their babies are dying is socioeconomics. Well, they tend to live in more deprived areas. Well, they don't tend to have as much money. Well, they don't buy the right foods. Well, they don't attend the yoga classes, the Pilates classes. Well, they have no money. And because they have no money, that's why they are dying. Quite an indictment on our society, the way we feel about poorer people and the way that we feel that they are undeserving of good care. A midwife, a student midwife at a conference that I was at, spoke about reaching people groups that others find it difficult to reach. And she called them underserved. And she used underserved as one word. And someone in the chat said, oh, you need to be careful when you write underserved. It reads undeserved. And I replied, and that's exactly how we treat them. They do not deserve for us to reach them. They have to come and reach us. But we think it's about socioeconomics. We think it's lack of money that is killing or putting Black mums and their babies at risk. And yet we know that a Black woman with a university education and a middle-class lifestyle is still at greater risk than a white woman with no money. And so we look at the lack of education. They don't come into our classes, Mars. They don't avail themselves of the wondrous knowledge that we have as birth educators. They don't come and find out how to do it properly. They're a little bit stupid because they don't recognize how much we know and how great we are at what we know. Their lack of education really puts them at risk. Too Black, too poor, too stupid. And then we think about Serena Williams, who the day after she gave birth via cesarean in a top private hospital, almost died because she said to her nurse midwife, I'm feeling breathless and I have a history of pulmonary embolism. It's just the drugs. It's just the drugs. You're fine. You're a bit confused. So she insisted and she insisted and she insisted. And so eventually they brought a doctor to her who took a Doppler to her legs and said, no, you're fine. Nothing wrong with you. And she continued to insist because she knew her body. And when they finally agreed that they would give her a CT scan because she said if she had that and a heparin drip, all would be well, they discovered that she had 3 blood clots in her lungs. They didn't want to listen to Serena Williams, who, let's look at the eugenics, was an incredibly fit Black woman. You know, arguably, and I take no argument in this, the greatest tennis player that we've known. Peak of fitness. Only difference is she's pregnant now. Socioeconomics. A multi-millionaire in her own right, married to a billionaire. Oh, okay, so it's not the money. Lack of education. Well, Serena speaks at least 4 languages fluently. So she's not too Black, she's not too poor, she's not too stupid, and yet she's still at risk of death. And what does the birth world do when we talk about this? What are some of you doing right now? They get defensive. They cry, what about white women? And there's a lack of awareness of self and of what's going on. So we've seen that it's not about eugenics. It's not about the fact that Black-bodied people are unable to birth their babies well, or because Black-bodied people have these predispositions, because I'm reasonably convinced that there are other communities of people that have some of these predispositions because of the way their lives have been. And so we make sure to treat that and listen and treat them. What happened to Serena is the reason she almost died was because no one wanted to listen to her. Because who wants to listen to that uppity Black woman who's being really aggressive and talking about these things as though she knows her own body, when this is our wheelhouse, this is what we do, and this is how things move on. So I have a question for you. Why do you feel defensive? If we're talking about a system and a structure and a society that has been built on the backs of Black bodies, that has been built to punish Black-bodied people whilst exalting white-bodied people, what is this defensiveness you feel? Is this defensiveness you feel because there's some truth that seems to resonate with you and it's something that makes you uncomfortable? And this is where your own thoughts come in. I'm thinking that the words that you say to make me confront the reality of Black maternal mortality means that you are calling me a racist, that you are telling me that I am this awful, awful person. Funny that, isn't it? We talk about the whole, but you make it about you. When a Black woman makes it about her, she's talking about the whole, or at least that's the way the messaging seems to go, because we all know that Black women, note, sarcasm, Black women are a monolith. If I'm speaking as a Black woman, I must be talking for all Black women. And the reason you know that you can poke holes into my arguments and tell me it ain't so is because you can probably find yourself someone Black, if not in the room, if not in the city, if not in the country, then on the internet, that will tell you something different to me, because we know that Black women are a monolith. I remember being on a parenting forum many years ago. The twins were babies. I just needed someone to talk to. Don't judge me, people. It was the middle of the night and I needed somebody to talk to. And one of the many, many threads, I said something and then someone else said some words, and a white woman, and I knew she was white because she told us, said that we were wrong. The two Black women that had spoken were wrong because she was married to a Black man and his sisters said. So her whiteness gave her the ability to go beyond our lived experience. So let's look at this next thought of mine. What about white women? So I was at a Black maternal health conference a couple of years ago. Do you remember those days when we could meet in person and you didn't need to take tests or wear masks, etc.? And the conference was named Black Maternal Mortality. And a senior NHS midwife, during question time, when people had raised their hands and waited and the mic was passed to them, snatched the mic and shouted, "What about white women?" Now, it is on YouTube, this conference, and I did have several friends messaging me frantically saying, "Breathe, Mars, breathe, don't deck her, not a good idea." I wouldn't have decked her, certainly not with my fists anyway. And I kept thinking, this conference is called Black Maternal Mortality. I don't understand where "what about white women" comes in. But now you see, we've changed that. We don't say "what about white women?" We say, "What about the traveling community? What about the trans community?" Because somehow turning the spotlight on Black maternal death isn't something people are comfortable doing unless everybody else is on the table. Everybody else is included in the pile. And what happens when everybody's included in the pile is that Black women once again go to the back of the list. Go to the back of the queue, sorry. When I belonged to a doula organization, and I was pointing out the importance of doulas for Black women, the importance of representation and advocates and voices and witnesses for Black women in the birthing room, I was told, not just Black women, all women. Because God forbid that we should focus in on the people who are most at risk. I have a lovely friend, Nicholas Pinnock, and Nicholas and I have big debates about all sorts of things all of the time. And we were talking about inequity, we were talking about racial inequality, we were talking about all the isms and marginalizing of people. And he said, you know what, Mars? If we looked around the room and we found the people who were most at risk and we raised them up, then we looked around the room again and we found the people who were most at risk and we raised them up. If we continue to do that, we would have no inequity, no inequality, because we'd be continually raising people up. Now, we know that when, as a society, we look after the least of us, we look after all of us. Another response from the birth world is, oh, I just didn't know. And there are some of you who through today have been figuratively, though if you did it literally, oh, I'd like to see those, clutch at your pearls and say, this is so shocking. This is just so upsetting. And in that you center yourself and you stop looking at the Black and brown women who are dying because you're uncomfortable. So what you do in your discomfort is you just turn away. Because if you're not aware, you don't have to do anything about it. But it's not about you. What? Everything's about me. This is my stage. This is my center. No. Defensiveness has no place. Oh, why are Black women so angry and aggressive and bullying, even when they speak in measured tones like this? Know this. I'm very proud of my anger because my anger keeps me moving. I'm angry that Black-bodied women, Black-bodied people are dying at greater risk, at greater numbers, in bigger proportions within the Western world than white-bodied people. What about white women? Well, if we look after the Black and brown-bodied women, of course we'll look after the white-bodied women, because we know in this Black maternity scandal that if it was a white maternity scandal, things would be done, targets would be set, marches would be had on the streets, laws would be changed, the medical curriculum would be looked at. What's going on? And there would be a complete and total awareness. Well, Mars, you know, I didn't have the greatest of experiences with a Black midwife, so I don't think race plays a part in this. Have you considered my lovely midwives and doctors and birth workers and birth keepers and doulas and whoever else is in this room? Have you considered what it is to be a Black midwife? They're more likely to have complaints made against them. Or someone in the room has a mic, has their mic on. It would be lovely if you could mute it just now, please. They're more likely to have complaints made about them from their colleagues, as well as the people that they're supporting. They're more likely to face suspension. We know that Black midwives are far more likely to be referred for complaint and suspension than white midwives, but we know that white midwives are more likely to be struck off. And they're more likely to be struck off because the reasons that they're referred through the complaints procedure is for serious things. I cannot tell you how many midwives that I've spoken to who are frightened just to do their job because if they speak up, they'll be complained against. Microaggressions from colleagues, tiny aggression. I'm not aggressive, Mars. I love everybody. I don't see colour. And because you don't see colour, you leave me silenced and erased. Because of course you see colour. Unless you're colourblind. In the true sense of the word colourblind. You see the blue sky, you see the green grass, or the brown grass, dependent on the weather. You see the grey rain. You see the colours in your wardrobe. You see the colours on your screen. You see the colours of the flowers that you bought. So you're not colourblind. You just use it as an excuse not to recognise the pain that someone else is going through because of the colour of the body they're in. And so the microaggressions can be as simple as a black or brown midwife walking onto shift and there's only one labouring person on the board and they are given that person to deal with. They're more likely to be given the most complex cases and the least support. I know of one senior midwife that no one would sit with her in rooms. When she walked in, if they were in conversation, the conversation would end, even though she was above them in band levels, even though she was running the ward that day. And there's a lack of promotion because their faces don't fit, because the decisions are made from people on high, and the people on high don't look like them. Ah, you're wrong there, you see, Mars, because Jackie Dunkley-Bent, she's the head midwife of England. Name 5 more. 4 more. 3 more. Angela Davies, who's one of my absolute most favourite people, said, I was listening to her at the WOW Festival, South Bank, again in those halcyon days when you were allowed to sit next to people. And she said, white women talk about glass ceilings. Black women don't even know that if they can be sure of the floor. Never mind the concrete ceiling above them. There's a lack of promotion for our black and brown midwives. How many do you know that are at band 7 and above? Why aren't they there? Oh, of course, because they're more likely to have complaints on their record. They're more likely to have had suspensions. Their faces don't fit. And so in order to stay within a nice, safe container to share their knowledge, they must just agree with the room so that they are not accused of being angry or aggressive. And so they do not go forward. When they're at work, they're expected to work harder whilst being criticised for less. They're not getting the breaks whilst their white colleagues are prioritised. You're lying, Mars, you're lying, am I? These are the things, the messages that drop into my email and my inbox on a regular basis. These are the conversations that the black and brown midwives are having with me when they meet me, because they know they'll be believed. They're given the hardest complexity person on the board whilst the others drink coffee. They're less likely to be given funding or time for professional development. I lost my shit when a black midwife messaged me, student midwife messaged me to say she really wanted her research to be about the disparities, really wanted it to be about black maternal health, her dissertation. And she was told by her university there wasn't enough information out there. And yet, on a regular basis, white midwives would drop into my DMs asking me for my time and my knowledge and my information so that they could do that same research. I spoke to a wonderful, older, experienced midwife just 2 days ago who told me that she's frightened of the repercussions when she speaks up in a room full of midwives that are less experienced than her. So what is my life right now whilst I'm talking to you? All birth activism, reproductive justice, training, speaking, creating, being a disruptor, being a trustee. I'm a trustee of Birthrights and part of the legal inquiry into Black maternal deaths. I do birth activism and reproductive justice and training as part of Abuela's Red Tent, where I work with Nicola McDear Goodall. I'm one of the consultants, co-founders of Play the Race Card, very lovely wee cards, which you can all get hold of if you just go to playtheracecard.co.uk. There ends the ad break. I'm part of the campaign Black Mums Matter 2, where we reached out to 200 Black mums and mums-to-be. We're in our last week of that campaign right now, and the reports that we're hearing back are people who are able to speak up, ask questions, go down different paths in their birth, and postnatally, of course, and part of Birthing in Colour, a group that meets the third Thursday of every month online, a safe space for Black and brown people. I'm a disruptor because I'm here to tell you that even with all of this work, Black women are still dying. The reason I like Play the Race Card is because what I hear a lot in this work is people say, oh my God, here they go using the race card again. It's not because you're Black, it's because your body's a bit pathetic and useless and you're a bit thick and you're a bit poor. It's got nothing to do with the way that I treat you because I treat everybody the same. Play the Race Card isn't a card that you play, it's one that's dealt to you. One that's dealt to you. So these cards were created as a prompt for you. Because you see, I believe that Black-bodied people, brown-bodied people have the right to thrive and not just survive. The floor isn't the benchmark. So what I want from you is that you take an action for yourself. Here, by the way, are the co-founders of Play the Race Card. I ask you that you take one action yourself. Miles, I'm a student midwife in the middle of a really big wheel and I don't really know quite what to do. Okay. What can you do? Even before you step into the birthing space, whether it's in someone's home or whether it's in a hospital. What can you do to interrupt your thinking, to change the societal narrative that tells you that Black women are demanding and non-compliant? I mean, what the hell does non-compliant mean? That's the language of the enslaver. What do your bookshelves look like at home? Your children's bookshelves? Who are the authors that you're reading? What films are you watching? What are you choosing to believe about Black bodies and white bodies? I remember being on I went to meet a friend and he was on an anti-racism course. I don't think it was called anti-racism at the time, but maybe it was. It was an anti-racism course. And I arrived early and they said, yeah, sure, come in. We're just doing a quick exercise. Come and sit with us whilst we do this. So I'm sat there and they're given a questionnaire. And the instructor gave me one of the questionnaires and said, don't worry, you won't be able to do this. And the very first question was, when did you first become aware of Black people? You're all thinking, yeah, good question, good question. Would you like to know my answer? I don't know why I'm asking because we all know this is rhetorical. I'm going to tell you anyway. When I saw a white one was my answer. And the instructor fell off his chair because it didn't occur to him that this could be, because we're so used to white being normal and neutral. And when we say woman, that what comes to us is a white woman. When we say doctor, what comes to us is a white man when we say midwife. This is why when COVID hit and the commercials came out, people are like, seriously, where are the Black midwives in all of this? Because we know the only people who can be good and true and altruistic and wonderful and giving and sacrificial are white, because the Black ones are being non-compliant in the back. How do you educate yourself? People like Nova Reid, she has a fantastic online anti-racist course. Look, I teach and run cultural competency workshops, etc., but they are just a beginning. And lots of you will just go and find a nice Black or brown bodied someone that works in the same field as you and say to them, oh, you can do it because you can speak for all Black and brown people. And therefore I can tick a box and consider myself educated. What else can you do? You can amplify Black and brown voices. Oh, for the love of God, do we really have to keep hearing from Black and brown people? Well, yes. Yes, you do. Because they're dying. And they're dying because you won't listen and hear. They just need to speak up. If a tree falls in a forest, English, A-level, Miss Cartwright, she could eviscerate you with one look. Taught us about existentialism, etc. And she taught us, if a tree falls in the middle of a forest, can anyone hear it? If a Black woman complains about her treatment, if a Black woman asks her question, can she be heard? Or is all that you see her non-compliance and the bullying? Take one action for yourself, because that one action might be the thing that saves someone else's life. Educate yourself. Why am I feeling defensive right now? Why do I feel attacked? How do I listen to and amplify Black and brown voices? I tell you so much about these race cards because I just think they're so important. They ask you to stop and think, to ask questions, to examine your own bias. Stop. Why are you taking this action right now? Think. Is this what needs to happen in this space? Ask questions. How are you doing? What am I not hearing here? Examine your bias. Societal narrative tells us that Black bodies aren't as important as white bodies. Our medical curriculum tells us to look and see the babies pinking up. Examine your bias. Don't be afraid of it. Do you know there's nothing wrong with making mistakes? This is where we learn, falling flat on our faces. What's the worst thing that happens? Well, we're flat on our face and we feel a bit stupid and maybe we feel a bit humiliated. But then we have a choice and we choose to get up and turn our stumbling blocks into stepping stones. What gives me hope? The agents of change, the people who are working to bring equity. These are 4 incredible Black women that I know personally, that I see the work that they're doing. The student midwives. So that said, Alicia here has now just qualified. Dr. Mummy. Ilian Morrison, mixing up motherhood. Dr. Christina Ketchy, not going to lie, total fangirl. Dr. Christina Ketchy, who says, do we truly believe that a few extra levels of melanin are the reasons why we die? Please remember that Black, brown women and their babies deserve to thrive, not just survive. You see, they matter too. So when you fall into thinking, oh, she's just playing the race card, remember that it's the card they've been dealt. Amplify the Black and brown voices. Follow the birth accounts. But the last thing that I want to tell you, the last thing that I want to share with you is this. How do we take care of one another in this space? How do we practice collective care? You see, the birth workers, the birth activists, the reproductive justice warriors, the people like me, and I'm not saying send me red wine, but seriously, if you want to send me red wine, just send me red wine. But how do we ensure that these people are loved and cared for and held and listened? And it's not as simple as self-care. It's about collective care. Jenny Joseph, the JJ way. Google Jenny Joseph, Jennie, in the States. They found that what they do has meant that the disparities close in her work. And she did something so incredibly expensive. She listened. She gave those parents a space, a safe container to be in where they were heard. Do you want to save the lives of Black and brown women, marginalized women, and Black and brown birthing people and marginalized birthing people within your care? Stop. Look, examine your bias, but listen. And when you listen, listen to hear, not listen to act. Don't go find yourself your Black midwife and say, are these things that Ma said true? No. Don't go and find your Black friend and pour out all of your non-racist actions on them. Stop tagging them in the George Floyd posts and the Black mortality posts. Do you think we don't live with this shit every single day? Wait, are you telling me, Mars, that that might be why they have these predispositions that lead to obesity and diabetes and cardiac issues and hypertension, because the sympathetic nerves are in a state of constant adrenaline and stress, even whilst they put their pink lippy on and smile at you? Society is what causes the predispositions. But you have the choice. Do you sit? Do you listen? Do you hold space? Do you examine your own bias without the defense? Never listening to that Mars again. She made me feel like absolute shit. Well, do you know what? So what? It ain't gonna kill you. But it seems to be killing lots of our mothers. And honey, don't even get me started on the near misses, where 83% Black African women are 83% more likely to have a near miss. Survival is not the aim. Thriving is. The floor is not the barrier, is not the bar. Black Caribbean women, 80% more likely to have a near miss. Asian babies, 60% more likely to die within the first year. So what can you do, my student midwife, doctor, doula, birth keeper, birth activist, parent? You can hold space and you can listen, and you can begin to practice some collective self-care. I ain't your Black friend. Don't come tell me about your non-racism. Show me your anti-racism. Oh, okay. Don't drop into my DM saying, I did this anti-racist thing. No, you're swimming in a pool of racism. Patting yourself on the back for not being racist doesn't cut it. Show me with your words. Show me with your actions. Show me with the lives that are being saved. Get out of the pool, people. Get out of the pool. I want you to turn around and look back and say, damn, do you see me? I was brave. I stepped up and I took note of the fact that societal narratives were there. And I was believing them rather than recreating them. So I'm not sure if I'm allowed to go on, and actually I am finished, and I'm not sure. Amber, you'll have to let me know if there's time for questions. I'm guessing probably not. I feel like I've probably ratted on a fair bit.
Unfortunately not, I'm afraid.
That's okay.
If you guys have any questions, you can save it for the student panel and then maybe we'll be able to answer them.
So, my lovelies, thank you for having me. Let's keep moving forward. Enjoy the rest of your day today. I'm going to go and do a little bit of self-care, which is not talk to white people for 10 minutes and just breathe out.
Thank you so much, Mars.
Thank you, Mars.
So that was a very great talk from Mars. I'm just going to share my screen again. Now, leading off what Mars has been saying, how do we dismantle bias? The American Academy of Family Physicians Foundation have created 8 tactics to identify and reduce your implicit biases. Now, I think this is a great tool that we can all use in our practice. Introspection, mindfulness, perspective taking, learn to slow down, individuation, check your messaging, institutionalize fairness, take 2. Introspection. Explore and identify your own prejudices, always struggle with that word, by taking implicit association tests or through other means of self-analysis. There are 3 implicit association tests available online. A popular one used was created by Harvard University, and it highlights areas in which you may hold bias and didn't realize. I have taken one of these tests myself, and I find it very interesting in highlighting bias I may have, which I am working on dismantling. Mindfulness. Since you're more likely to give in to your biases when you're under pressure, practice ways to reduce stress and increase mindfulness, such as focused breathing. If you're feeling stressed, it's important to sometimes take a step back and evaluate what you are doing and what the best way is to action what your client needs. If you're under pressure, ask for support and seek advice from your peers and colleagues who can give you a fresh view on the situation. If you feel like the care your client needs is outside of your competency, get help and support from someone who has the required skills necessary to look after your client. Perspective taking. Consider experiences from the point of view of the person being stereotyped. You can do this by reading or watching content that discusses those experiences or directly interacting with people from those groups. Research how women of color are stereotyped and the history behind these stereotypes that are portrayed in society. They may give you a better understanding of why they are not fair or accurate. Remember, every client should be treated as an individual, and they all have their own set of required needs that should be met. Learn to slow down. Before interacting with people from certain groups, pause and reflect to reduce reflexive actions. Consider positive examples of people from that stereotyped group, such as public figures or personal friends. Once you understand bias and stereotyping, you'll have a better understanding of how this affects the care you provide. And you'll be able to think twice about your actions and how you communicate with women of color. If you have friends or family from different ethnic groups, think about how you would want them to be treated in a vulnerable situation. For example, they would want to be listened to. They would want to be treated with respect and their dignity protected. You would like their requests met when possible, and you would not want them to be dismissed if they had a concern. Individuation. Evaluate people based on their personal characteristics rather than those affiliated with their group. This could include connecting over shared interests. This again goes back to treating clients as individuals and meeting their individual needs rather than assuming what certain women from certain backgrounds may need or want. Check your messaging. As opposed to saying things like, we don't see colour, use statements that welcome and embrace multiculturalism and other differences. Using phrases such as I don't see colour erases people's identities. It is good to acknowledge colour, and there is no shame in that. Honour every woman's beliefs and practices that they may want to have incorporated in their care, and provide them with all the risks and benefits so that they can make informed personal choices. Don't just assume what they may want. Institutionalize fairness. Support a culture of diversity and inclusion at the organizational level. This could include using an equity lens tool to identify your group's blind spots, or reviewing the images in your office to see if they further or undercut stereotypes. Does your trust have something in place that acknowledges the statistics? And is it working to reduce them in your area? If they do, find out what kind of work they are doing and how you can improve your practices with the support from your managers, supervisors, and colleagues. If they're not, then maybe this is a bigger conversation that you need to be having with your management team. My Placement Trust has a campaign that is working on raising awareness on racial bias and is introducing interventions to improve outcomes for women of colour. And I think every trust in the UK needs to follow suit. Take 2. Resisting implicit bias is a lifelong work. You have to constantly restart the process and look for new ways to improve. There is so much information out there that allows us to learn and dismantle our bias. There are many podcasts in which service users discuss their experiences in the NHS and how systemic racism plays into how they are treated. Learning the history of how historically people of colour, and especially women, were treated hundreds and thousands of years ago in medical research trials will help you understand where the systemic racism in healthcare comes from, as well as the stereotypes such as Black women have a higher pain threshold. That is not true. I have included at the end of my presentation lots of literature that is away from the colonial education system we are privy to, which will help broaden minds and give a deeper understanding of what people of colour and women of colour have to face in relation to their health. So, how do you think you can use this tool in practice? Does anyone have any ideas? I really want everyone to think about all of the points that I've just said and how can this be applied to the care that you provide. Miss?
I think for me, it's going to be primarily learning to slow down. Learning to slow down my thoughts and my words and stop and take perspective before opening my mouth. That's going to be my thing, I think. Yeah.
Thank you for sharing. Anyone else?
I'm due to start my midwifery training in September, so I'm gonna definitely make sure that when we're being taught about conditions and things, that, you know, I'm not just taking on face value that the textbook tells me to look for a baby going pink or this, that and the other. I'm actually gonna sort of say, well, what about, you know, black and brown skin? How will this present? So that from the very beginning of mine and my cohort's education, we're becoming aware that actually not everything presents in the same way in people with different skin colours and stuff. So that's what I'll take forward, I think.
Thank you, Jane. Does anyone else have any thoughts about what they'll do to include this in their practice going forward?
Hiya.
Yeah.
I was just thinking that, so I qualify in September, and a lot of it is about, I think, using the voice that I have and speaking up more, you know, because I can think back through my 3 years as a student, and there's so many times when I should have said something and I don't really have any excuse. So yeah, using my voice, I think, is mine.
Yeah, use your voice, advocate for the women who aren't being listened to. Thank you for sharing. Anybody else? Jasmine has said in the chat, not allowing things to slide when I see something wrong. Yes, I think that's something we all need to do going forward. Does anyone else have anything they want to share? I know it's been a long day of talking, but we really need to come together and think of how we can bring down these disparities in maternity services. Women of colour deserve to have the care that they should be getting.
I think what I've taken from this is I'm going to try and teach my students to have more of a voice. So not just teaching them in lectures to have a voice, but when they go out into practice to have a voice as well. And if they're not confident enough, to bring it back to us so we can not have their voice, but help them.
Yes, that's good. Create that foundation of having a safe place to talk about something and report something if it needs to be reporting. Sharon has said in the chat, sometimes I feel a bit stunned at the time I miss the chance to speak up. I need to commit to coming back later when I figure out the right response, challenge, acknowledgement. Absolutely. Sometimes you need to process what is going on before responding. So it's totally okay not to respond, not to react there and then. You might need to take a step back and think about the right way to go about this issue, and that's okay. Just don't let it go.
I think there's also a fear of speaking up. So especially when we've got, as student midwives, we've got to get our books signed at the end of the day. And it's like, sometimes you hear things and you're like, you want to say it, but you're like, you feel like you've got to pick your battles, because if you speak up, what's going to happen? And I know, like, when I've spoken to other students, there's a huge fear of speaking up. And yes, it's very difficult, and we're also not believed. So I think what's helped me last year was like talking to other like Black and brown students. Like, we have like a group chat, or talking on social media and stuff like that to other people, and just reflecting about our experiences. Because I think that really helps, like having that support, because I don't think I would have made it through last year if I didn't have that support network. And I didn't meet you, Amber, and you know, like that's really helped me get through. And I think that's what helps as well, because it's so difficult on placement when you're there, you're fresh, and you don't want to speak up, and you hear things and you see it, and it's like you're like stuck and you don't know what else to do. But I think speaking to others, and also speaking up as a collective, so getting a group together and speaking up about it, can help.
I agree. Thank you, Renee. So everybody, practice supervisors who are on this conference, lecturers, cohort leads, CPFs, please listen to what Renee said. Make a safe space for students to come to you and report something when something is happening. Do not penalise them by not signing their books or MPADs because they have reported something. That is not the way we're going to dismantle the disparities in maternity services. No student or staff member should be penalised for reporting misconduct and racism or prejudice or bias within maternity services. Alice, you have your hand up?
Yes, I do. I was just going to say about the way that I speak up. I often speak up from a place of anger and emotion and don't always get what I want to say out in the correct way, in the way that people are willing to listen. So I guess for myself, it's the way that I speak out, and to be able to come at people with facts and figures, and not necessarily always from my heart. Like, it is going to be from my heart anyways, but to do it in a way that people are willing to listen rather than from quite an angry place, which is going to be difficult. But I think it's really important, because people aren't going to listen to me if I'm coming at them with anger.
Yeah, I think that's a really good point to make, Alex. It's okay to go away and think about what has happened and calm down and collect your thoughts and then readdress it. So that's a good point for all of us to take on. Neve?
Hi, oh well, thank you firstly for putting this on today. It's been really, really amazing, and happy International Day of the Midwife to everyone out there as well. It's great to celebrate with such amazing midwives and midwives to be. But firstly, I just wanted to kind of speak in support of Renee and hopefully motivate her to push forward with her thoughts about speaking out and feeling confident in doing so, because I'm a really experienced midwife and lecturer at the minute, and it's still difficult even when you qualify and have years of experience and move on to other aspects of your career. So I'm in a position at the minute where I've just moved to a new university, and there's definitely not institutionalized fairness. So I'm really grateful for today, because it's helped me sit and be calculated about what movements I can make in an impactful way to have a more positive influence on that. Just simple examples of our skills room has one black mannequin, rhesus Annie doll, compared, with a ratio to maybe 40 or 50 white ones. We've got an international Center for Racism, research surrounding racism, and I went to the open day a couple of weeks ago, and it was all white middle-aged men. So there's some barefaced lack in institutional fairness there. So I just feel really empowered and motivated. I feel like I've got some really useful tools that I can bring forward to challenge that and try and take responsibility for what I'm putting out in terms of the education I'm providing for all of my student midwives and giving them the best opportunity to be the best midwives that they can be. So yeah, thank you very much.
Thank you for joining us, and thank you for sharing with me. So let's have a look at the chat. Joy Palmer has said, unfortunately, the students do not have any rights when members of staff, practice supervisors act up. That is what I have noticed in my experience. Of course, we don't have many student rights as students, but if we address it, the issue of the practice supervisor, that's one way. If we feel like it wasn't received well, or we can't do that, go to your CPF, go to your link lecturer, talk to your university, talk to the senior midwife in charge if you feel like you can do. There's always something you can do, and we can't control the outcomes of what we report, but I think as long as we keep pushing and using our voices and advocate and try our best, that's the most important thing we can do. So should we have a quick 5-minute break before Jade comes to talk to us? We'll come back promptly, please, at 3:30, because that's when Jade Sullivan will be talking. So I'll see you promptly at 3:30. Thank you. Okay, so it's now time for me to welcome guest speaker, Jade Sullivan. Let me just stop sharing. Jade, are you there?
Hi, Amber. Can you hear me? You can see me.
I can hear you. Hiya.
Hi, how are you?
I'm good, thank you. How are you?
Thank you. Thank you for having me today.
Thank you for joining us today. I really appreciate it. So are you happy to go on and tell us your experience of the NHS maternity services?
Yeah, so I just wanted to tell you a little bit of background about myself. I had quite a journey to being a mother. I had a miscarriage, and then I tried, had I think two attempts on the NHS with IVF. And then we found a private doctor off Harley Street, Mr. Taranisi, who identified that I have something called high natural killer cells. And that means when my body gets pregnant, it thinks it's an infection and kills it. And obviously there is the statistic that Black women are more likely to also have stillbirth and miscarriage. So I actually wonder, and this is something that's not really recognised on the NHS, I don't know whether that has changed, but I was treated with something called IVIG, and that's something that's recognised in America and not in this country. So I think that's quite an important medical thing that is recognised within the private healthcare system that's not recognised, and may be contributing to a lot of Black and all women's pain and losing babies. I fortunately got pregnant when having this treatment with twins. So I was, at that time, I was 33 years old. So that could be considered an older mother. Unfortunately, I went into early labour. My waters broke at 29 weeks, so like 10, 11 weeks early. And my husband rushed me to the hospital where I was given steroids for the baby's lungs. I think that was on a Thursday. And my labour I was in quite a lot of pain, but I was okay. And then Friday it kind of calmed down a little bit. And I was constantly monitored with the heart monitors for the baby's heartbeats. I was given no pain medication whatsoever. I think by maybe Saturday, the labour came on much stronger. And I even had a show. I was being looked after by, I'd say, a mixed heritage midwife, but she may have been light-skinned Black, and a registrar doctor that was an Asian, quite young, maybe a trainee, I don't know if he was a trainee, but anyway, quite a man. And they asked me to poo in a pot, and all I could hear was my grandma, because I think they wanted to test something in the poo. And all I could hear with my grandmother said, "Jade, you can't poo in a pot." And I just kept going to the toilet. So I was put into a room on the ward, I guess because I was having twins and maybe I was quite high risk. They put me in my own room, which was very nice. And I was actually at Chelsea and Westminster Hospital. So when they speak about low income areas, this isn't a low income area. It's one of the most plushest hospitals you'll ever visit, with fine artwork everywhere. And I was placed in this room and left with this show, and the birthing experience increased. And obviously this is my first child, but or children, twins. And the pain was so bad that I was actually putting the electric bed up and down just to try. I felt like I had the only way I could describe to you is I felt like I had aliens moving around inside me, and I was in so much pain. And they just left me. When I say left me, they just left me in the room. I guess
they didn't offer you any pain relief or anything?
No, nothing at all. I don't. Did I have gas in there? Maybe gas in there. I can't remember. I was just left. I was just actually left in the room. They just come every I guess few hours when you do your checks or whatever to check the heartbeats. But I was just left throughout that night. I'm just told to put in this pot, even though I'd had a show. And I'd obviously done my reading, but it was my first babies. But it was by the grace of God that the changeover happens. Now, in all my experiences of hospitals, you know, there's a lot of, you know, there's obviously more patients than people to look after them, it seems. And, you know, everybody seems rushed off their feet and nobody's really given that much time, which it is what it is. But basically, it was by the grace of God on the Sunday afternoon when my labour had calmed down a bit, and by 1 o'clock there was a changeover, and a new, so the old staff left for the night and the new staff came, and I was wiggling on a chair, and I was just wiggling, and the white female doctor, she said, "Jade, I'd really like to check you." I'm like, "No, I'm fine. You know, it was much worse yesterday. Like, seriously, I'm all right." Do you know what I mean? It's fine. She's like, "No, I'd really like to check you." I said, "Okay." So I got on the bed and she checked me. She's like, "You're 10 centimeters dilated." And I don't know if anyone's ever been to Chelsea and Westminster Hospital, but it's kind of like you're at one end of the hospital. So I was rushed. And by the grace of God again, I was rushed to the birthing rooms, but none of them were clean, which was God's grace. So that meant I had to be put into the theatre. Now, when you have twins, there's probably about 10, 12 people in the room. And so it all happened quite quickly. Thankfully, my husband Tyrone got there in time, and I'm there and I'm pushing, and I'm silently birthing, because I don't know, this kind of serenity kind of came over me. And I'd read a lot, I've read Ida May as well, and about, you know, silent birthing and not need to scream and just be calm, and, you know, you're giving birth as women have done throughout the centuries, you know, from the beginning of time in Africa. And I was going to the midwife, "Oh, sorry, I haven't brushed my teeth." And she was like, "Don't worry about that, just push." And Ben came out, and he was tiny. I mean, they were 1.1 kg. And I was like, "He's not crying, Tyrone's not crying." And Tyrone said he's got big, bubbly eyes, Ben, and he's looking around and with his miserable little face, like a moany old man. And I was like, "Oh, thank God, you know, he's fine." And then everyone was like, "You're doing really well, Jade, you're doing great." And then the atmosphere in the room changed, like suddenly. And the beepers were going off for the heart monitor. And what can happen with twins is obviously there's instantly more room in your belly. And I think what Eva the Diva Rose said, "What's going on here?" and moved her arm, and it got caught in the umbilical cord. So everybody changed, like the atmosphere just totally changed. It was very scary. My husband got rushed out of the room. I think they gave me a pill or maybe an injection, and I was put out to sleep for like 24 hours. So that is my birth story with the twins. Yeah, so then basically I had the twins. I was out for 24 hours. I remember waking up and I had to have an emergency C-section with Eva. And I just remember being in a lot of pain, and, you know, blood drips and all sorts connected to me, and my babies weren't near me. 24 hours later, I find out my husband's sending pictures of our babies in plastic bags to relatives because he's so excited to have these children that we've been trying for 4 years. And I was wheeled to the NICU ward, and I've never felt a pain or a sensation like it. I saw my baby Eva, and she looked like a little famine baby, the ones you see on TV, so small, 1.1 kg, tiny, skin and bones, and blue with bruising and green, and Ben in separate incubator. And what they don't tell you and what you don't know until you're a mother, until you've had these, you know, your breasts are going because your stomach starts contracting, and the pain and the trauma of it all was something I will never forget. I wouldn't wish any mother or my worst enemy to ever have to go to NICU, and ever, because all it is bleeps and emotional roller coaster, because from one day to the next, infections and babies look ill and babies die, and it's very, and you have to pump constantly, milk every 3 hours with strangers in a room, and it's very strange. And I was put back onto the ward. So when you have a NICU baby, you have to go back to the ward, and that was really quite upsetting, because everybody's got their babies and they're screaming babies, and your breasts know that they're screaming babies, so they want to feed them, and it's all very bizarre, but really bizarre, horrifying experience. But thank God the twins are fine. They're 9 now, and they were in there for 6 weeks, a very long 6 weeks. But they came home and they've grown up very well. So thank God for that.
Yes.
After that, I'll just tell you about my other life experience. So when the twins were about 2, I got pregnant again, this time naturally, not through IVF. And I was really happy. But then I started to have some discharge, and I wasn't, you know, didn't seem to be going well. And I went back to my private healthcare doctor after going to the NHS and asking for an early scan, which they wouldn't give to me, even though I was an IVF mother, an older mother, previous miscarriages. Thank God I went back to the private clinic, because they kept scanning me early, doing my blood test, and they through the early scan, they found out it was an ectopic pregnancy. So then I was rushed to Chelsea and Westminster Hospital, where thankfully they saved my life, because my stomach was filled with blood. And then a few months later, I got pregnant with May, who's now 6. And when I got pregnant with May, I went back to the same private healthcare to have my IVIG treatment. And very early on, because I'd had my twins so early, they checked my cervix. And what they found out was, instead of my cervix being maybe 5 centimeters long, it was like 1 centimeter. So I had to have a surgical stitch. And she survived that. And with the ectopic pregnancy, I'd had my fallopian tube, one of them cut. But this little miracle May, as I call her, she'd managed to come from the ovary that didn't have a tube on, didn't even know that was possible. Anyway, she then also decided to make an early appearance. So Miracle May came about 6 weeks early, and had a C-section, which was, you know, fine. But when she was born, she was about 4 pounds, I think. So they were still concerned about her weight. Well, I think she was fine. So they took her straight into NICU to, you know, feed her up and get her bigger, I guess, as a precaution. I was feeding her, well, you can't feed directly, breastfeed, but you know, pump your milk, you go back to the ward, you pump your milk, you leave the milk, they drip feed her, etc. So it was a familiar ward. I'd been there 3 years earlier, similar nurses, similar doctors, similar healthcare professionals. And then the next morning I went there, and there was vials of blood. And I was like, Eva, I'm gonna call. And there were vials of blood, and I was like, what's going on? And they rushed me into this room, and they said, the doctors called me into the room, me and Tyrone, and they were talking about something about my platelets and what did I take, what medication had I taken when I was having her, etc., etc. And I was just like, well, nobody said this to me before. Anyway, we saw when they did the X-ray, and it was a feeding tube, but nobody wanted to admit it. and it was all a big cover up, and this cover up went on for like a couple of weeks. And you can imagine the stress that could cause a family who've already had premature babies, got 3-year-old twins at home, husband's been left again to look after twins, and that was very, very stressful. The fact that they didn't admit to something that had gone wrong until about 2 or 3 weeks after, and I'm very intelligent, I've got a master's, and I don't suffer fools, and I'm Jamaican, and when something needs to be said, I will speak out and loud. And I'm very open and honest, which they weren't. So basically, I went to the mental health person on the ward, on the NICU ward, and I was saying to them, you know, this really stressful situation for my family. I just want someone to speak to my husband. You know, I've just been cut open, my breasts are going, I've just given birth. Please, could you, you know, get a perinatal nurse to just speak to him and explain this to him, because I also have a pre-existing condition of bipolar disorder. Whether I believe it or not, I do not know, but this is the facts, and this is what it is, and I just need some help. Just to explain to my husband to treat his wife nicely, because it is very stressful being in NICU. So this happened. There was, I don't know whether you remember, in 2015 there was eclipse of the sun, and everything was supposed to go down, and it didn't, but it was fine. And it was a Friday, and I'd organised for my mother-in-law to come and look after the twins, and my husband to enable my husband to come and see this perinatal nurse or doctor, whatever. And that didn't go too well either. So and I said to this guy, I said to him, please, can you give her you know, a synopsis of my, you know, diagnosis, be very honest, and this is what I need. I don't want to go down there and explain my life story. That's not what it is. I just want this help. We went down there, whether he hadn't sent the notes or she didn't read the notes or she was just new to the system. I sat there for 45 minutes. She made me relive all of my trauma and all of my life story in 45 minutes. So obviously I was speaking quite fast. I tend to speak fast anyway. And at the end of it, she said, yes, I can confirm you're bipolar. I was just like, I didn't come out for this. I may have stormed out the room because I was really upset. And I was like, I've just got to go back and feed my baby. I'm sorry. Before they do something else, I've got to get out of here. And I need to be away from you because I'm really quite angry right now. And then the next thing I know, I'm feeding my baby in NICU by the incubator where the wires are attached. You can't even feed your baby freely. And I am accosted by 3 mental health scary white people who come to section me.
No.
Yeah, so that's my story in a little nutshell. And then I was put in a mental hospital around the corner from here because I didn't want to be away from my children, who were 3, whose mummy just disappeared. The healthcare professional came to my house because I hadn't been taking any bipolar medication for like 7 to 8 years because I've been trying to get pregnant, so I knew I was okay. The healthcare professional, the health visitor, she came round to my house and told me to tell my twins that I'm going to Sainsbury's. Mummy didn't come back for about a month. And I had to breastfeed. I had to find out about the drugs that they put me on, which a doctor confirmed in the end they made me very ill, like Doulas. But she would never admit that because she would probably lose her job under the doctor who prescribed it. Anyway, it is what it is. I'm here to tell the tale.
And thank God.
Well, thank God, yeah.
Yeah.
And I felt I did suffer from really bad PTSD because once this doctor confirmed, I had really bad PTSD when I came. I was fine. I got on with, you know, getting back to my family. I had no rest. I was pumping when I was in there. I was sending cabs with my breast milk. I had no rest. To go home to a newborn premature baby and twins, you have no rest. And then I had nightmares about the drugs they gave me and what it made me do in there. And then a year later, the Dr. Monica Bersham, she said, I'm leaving this hospital because after my stay at the mental health Gordon Hospital, she said, you know, Jade, you've done really well. I'm really proud of you, because she's a wife and a mother, so she kind of knows what goes on when you have a baby and in relationships. And basically, I got finally plucked up the courage to call her, because I was having really bad PTSD, nightmares, waking up in cold sweats, flashbacks. And I finally thought, I'm going to call this woman, I don't care. And I phoned her and she said, I'm leaving this hospital. I'm going to work with the children in Chelsea, working with mentally ill children in Chelsea, Kensington and Chelsea. I said, can I ask you one thing? She said, yeah. I said, can you tell me, the drugs you gave me, did they make me ill? And she said, yes. And then, you know, I tried to phone up lawyers and, you know, to kind of, I felt like I'd been imprisoned and I felt a sense of injustice. And you phone up lawyers with anything to do with the NHS, and unless somebody's been seriously hurt or, you know, disabled or dying or dead, they're not going to look into it or help you. So after that, I did have a break a year after, but I didn't take any drugs, and I've been drug free from May 6th now, and I'm here to tell the tale.
Well, I'm glad that you're here to tell the tale. And I know this isn't, I know the answer, but I just want everyone to make sure that they know the answer. If you were a white woman, would any of these situations have happened?
I don't believe I was heard as maybe a first-time mother, as a Black mother. I think, as we've heard with other people speak, there is a saying, the strong Black woman, and that is a stereotype that is put against us. You know, if you look back in history, there was like medical history, there's like Sarah Bott, who was traumatized, and her body was, you know, used in a terrible way. And, you know, there is an association with Black women are stronger, Black women can take more pain, you know. There's also, from a Black person's, women's point of view, you can take some strength in that, you know, I'm strong, I'm Black, I'm, you know, nothing's going to hurt me. But, you know, we're human. Race is a social construct made up by white men to put Black people in boxes. There is no such thing as race. There is a human race. So the strong Black woman stereotype needs to be quashed in order to be heard, in order for any mother, any woman to be heard and listened to. There's also obviously the aggressive Black woman. So I think it can take two kind of things. So when we're maybe preconditioned to know that we are seen as aggressive, so we don't want to come across as aggressive. So maybe when a Black woman is in pain, maybe she's not showing it as much as a white woman when she's in pain, who screams when she's giving birth. Maybe, you know, we need to ask the right questions to see how much pain she is in, not the pain that she's projecting. I think that's really important, because maybe we are conditioned to, you know, lower our tones and our voices when stressful situations happen. And that may not be apparent where other people may scream. But also in screaming and shouting loudly, when it's emergency, women need to speak up and they need to be heard and listened to. And I was listening to, I've listened to the conference all day, and I just want women to, and your future midwives and the doctors and anybody else who listens to this, when they're treating patients, to think of equity. And are you going to treat a white woman that looks like Kate Middleton differently to the way you're going to treat a loud teenage Black girl? Who are you going to run to first? And if you're going to run to the white woman first, why? I think these are the questions you need to ask yourselves.
I agree. I agree. Thank you so much for sharing your story. I know it wasn't easy. How do you feel? Go on.
Sorry.
Would you like to answer questions, or how do you feel?
I was just going to say a few more things of my observations of being in hospital lots of times. I think that doctors, I think there's a hierarchical system within the NHS, and it's a whole cultural change. I appreciate that your student midwives, you know, come to this event and listen to other events like this and to raise their voice and help support Black women. But Black women are dying, and this is an emergency. And as Mars has shown, the statistics have got much worse in the past 15 years. I think this is a real cultural change for the NHS. It is an ailing system, an out-of-date system. There are too many people to treat to give them the appropriate care that it needs. I think that doctors, often middle class, can be very arrogant. Even, you know, medicine in general, even like the tablets and things have got, you know, Latin names and things that you can't remember, and doctors need to listen. And the cultural change that needs to happen in order for you midwives to be supported needs to come from above. It needs to a leadership. It's a whole cultural shift. When, you know, midwives could, you know, as you know, there are a lot of Black, African and Caribbean midwives within this NHS system, disproportionate midwives as opposed to doctors, I think. And their voices need to be heard. Women need to be heard as midwives, but also, as Mars said, when we're giving birth, there's a thing called mother's instincts and women's instinct, and we need to be heard and listened to. And because we know our bodies best, even if we haven't experienced births before, we know what hurts us. We know when we're in pain. And I think that the arrogance and the system within the NHS doesn't necessarily support the midwives or the patients the way that it needs to, due to the arrogance, classism, feminism, all the isms that need to be quashed. I think there are a lot of cover-ups that go on in the NHS, and I think it's important that you guys have the ability to speak out, and you're supported by your unions when you do so. And I think that the implications of the mental health on Black women, I listened to a report that had been done in America that said racism causes Black people to be physically ill. So not only mentally ill, physically ill by the racism they encounter from birth. And this needs to change, and it needs to be taken really seriously. We can't wait another 15 years for another report. This is too serious, and Black women are dying, and babies are being born without their mothers, and mothers that have done their time as mothers are having to bring up their grandchildren, or men are being left alone. And this has a wider implication for society as a whole. And there's also a statistic that says 75% of Black women, the ones that, you know, are lucky enough to survive, have PTSD 18 years after birth. That's not good enough. Things change.
Yeah, things do need to change. Thank you so much for taking the time to talk to us. Does anyone have any questions for Jade? You could put your hands up and I could just call you out as we go. Femis?
Yeah, I was actually curious more about the IVIG therapy. Now, I do know a little bit about IVIG. So it's intravenous immunoglobulin, and it's also a treatment for hyperimmunoglobulin E syndrome, which is also known as Job's syndrome. And I know that 15 years ago, it cost £160,000 a dose, because it's an incredibly concentrated plasma product that can't be reproduced by other methods. And if you've got it's interesting that your private doctor immediately treated you with IVIG therapy when it wasn't available on the NHS, Jade. I'm appalled that it's not on the NHS more than anything else, when I know it is available.
So I had May 6 years ago. I don't know if I know that Oxford were doing studies and trying to help women with this treatment. I was treated by Mr. Taranisi of the ARGC clinic.
He's brilliant, isn't he?
Yeah, he flew and he's been quite prolific and on Panorama, but that's where Rod Stewart and Penny Lancaster went to have children. So if it was good enough for them, it's good enough for me, and his stuff works. So basically,
he is a brilliant man.
Yeah, he's very cool. And my blood was flown to America and tested for £800, and then I think each treatment for IVIG was about £1,800 of treatment. So I'm not, I understand, this is the NHS, but if you think about the women and the mental health impact on society.
Well, this is what I mean.
Women that are, not able to have babies, keep losing babies, end up in mental health institutions for years, or kill themselves, or, whatever else can happen, end up on the streets because they can't have babies, because Black women are supposed to have babies, because that's what, we all do. I think that this is something that should be common knowledge. And
I absolutely agree with you. I'm appalled that it isn't as common knowledge as I thought it was, actually.
Mm-hmm. Yeah.
And so I wanted to thank you for sharing that particular part, because my jaw was just open the entire time when I was screeching, what the entire time. And also to say thank you so much for sharing your I can't even begin to imagine what you went through, and I'm so sorry that you had to, because nobody deserves that treatment, and I'm upset for you, not for me at all. I'm upset for you and the trauma that you experienced.
Mm-hmm.
And I am furious. I am so angry that they came to the NICU and marched you off like that. That should never have been allowed to happen, Jade.
I know that you're very emotional about Jade's story.
Sorry, I'll be quiet.
Okay, I appreciate it. But,
I think thank you for speaking with your heart, and I appreciate that. And I want to cry, but I'm not going to, because I've spent 6 years kind of trying to get over this. And the reason why I'm speaking is to help others. And the reason why I'm speaking is to ensure that not one other woman goes through what I've been through. I don't think it's good enough to just have empathy or to buy a book. We really need transformative action. I think, as Mars said, if this was happening if white women were 4 to 5 times more likely to die in childbirth, it would be front page news. Boris Johnson would be talking about it. Kate would be marching about it. Can we get Meghan Markle talking about this? What can we do to make this urgent? Because tomorrow, today, another mother's going to die. And if we're talking about money, and that's what everything kind of boils down to within the NHS, the implications of not treating this have wider implications for society, mental health, how the children of the future are within their own mental health. I mean, my son, he's still, he hasn't seen me in the house for, more than 10 minutes, he comes to find me and gives me a hug. He's still traumatized by it. And I didn't really get the support that I need or wanted. I got some support, but it was too late. So I just want everybody to really kind of shout out, speak out, and write to your MPs. 5 times more likely, 5 times on Instagram are doing great things with their campaigns, but this should be, I watched the Parliament debate it, and all the MPs are kind of gathering, but if we keep on to the MPs, if we, as sisterhood, we march together, when we can do that, white women managed to do that for when somebody died, one lady died in Clapham. Nobody's managed to do that for black women, 5 times more likely to die in childbirth, and I found that an absolute travesty and really insulting. So yeah. And
I agree, and I think it's really important for everyone to listen to what I'm about to say. When a black woman, a brown woman, a mixed ethnicity woman is telling you a story of her trauma, listen, understand how she feels, but please do not make it about yourself, because it's not about you. Okay, you have the right to feel empathy and be shocked and ashamed by how these women are treated, but remember, it is not about you.
Yeah, okay? I just want all doctors and nurses, you go into a caring profession, I would like equity. I would like to make sure that when my daughter gives birth, my daughters give birth, and my son has babies, this is not still the statistic. I want doctors and nurses, what they should be doing is treating people as you want to be treated, as your own family.
Yeah, I agree. I think we'll leave the questions there.
I'm just so I appreciate, because it is quite an emotional, traumatic story, and I appreciate that emotion, because I feel it, and I'd probably be crying too if somebody else told me, and I have finally stopped crying over it and been able to speak. So thank you, and I appreciate your emotion that you shared with me, because you're a lady, and as a lady and a mother, I think as women we have a sisterhood and a bond that is really important, and that's why a lot of women are midwives, isn't it?
Exactly. So thank you, Jade, for sharing your story and taking the time to talk with us today. We'll take a short break and then we'll return at 4:15 for the student panel. Okay.
Thank
you.
Thank you.
So now it's time for the student panel. And this is the time where Jordan, Renee, and myself will answer any questions that you might have and have a conversation about what students and registered midwives can do to bring change, to end the disparities and create better outcomes. So let's have a look. does anyone have any questions? Should we start with the questions? Renee and Jordan, are you there?
I am here.
Hi.
Hi, everyone.
Hi.
So let's have a look. If you have any questions, please put your hand up or put them in the chat and we can answer them for you.
Everyone's gone quiet now.
I know. Okay, well, let's start the conversation off. Jordan, what do you think needs to happen to create change in maternity services?
I think, like, from a student midwife point of view, I think it's just really important for people to not be scared and to speak up. Obviously, they have fresh eyes. They're new to the profession, and hopefully they would know wrong from right. And I know, as Renee mentioned earlier, like, you've got to get your pad signed, you've got to potentially work with that same mentor again. Like, it's awkward. People, we're not used to like coming out of our comfort zone and like essentially complaining about something. But if you could make a woman's experience better, save a life, or just make her overall comfortable, why wouldn't you want to do that? Like, there's loads of other ways. You can do it anonymously. Yeah, I just think the first thing we need to do is have our eyes and ears everywhere and just speak up. Like, you need to be the voice for that birthing person. Like, they don't, especially in COVID, they might not have their partner there. Like, they're going to be alone. So yeah, for all the student midwives in placement, qualifying, like, just speak up.
Yeah, and like I've said throughout the conference, if you're having trouble speaking up, then you can report things to your CPF, your link lecturers, cohort leads, etc. So if you don't feel comfortable doing things yourself directly, that's okay. But there are other channels in which you can report things as well. Renee, what are your thoughts? What can we all do to create change?
I think as students, especially Black and Brown students, for experiencing like racism on placement or seeing it, I think we need to be able to reflect on it. So I don't know about other universities, but my university allows us to do a reflection session. So we just will sit and talk about what's happened on placement, and we just go through what we learn, what we gained from it, what we've learned from it. And I think that's another way of teaching other students also to become allies for us, because I think that's another thing that we need. We need more allies. So we need more people to speak up for us, because if you come from like a white background and you have a more privilege, so therefore you can speak up on our behalf.
Mm-hmm.
So if you see something happening, you can say, no, I don't like that. And if you're like a student rep, you can say, right, can we do something as a collective to stop this? Because it can become a lot for us. You know, there's a lot of racism that we have to deal with, and it's our lived experience every single day. Every time we book an appointment for the doctors, we're like, oh, you know, are they going to treat me in a racist way? You know, when I go for dental surgery, are they going to give me surgery, or are they going to refuse because I'm Black? You know, and so this happens all the time. So we need to be believed, we need to be listened to. And we also have to remember, when we went and we applied for this to get into university, we all sat down and in our interviews and said about the 6 C's and equality, and we're going to do this and we're going to do all of this stuff. And then we've kind of forgotten it, because you can sometimes sit in with your cohorts and you can hear either a lecturer saying something racist, or they can see something going on that is not right, and people being treated unfairly, and nothing's said. And we need to speak up, and everyone needs to speak up as a collective. I think if all of us stand up and just say, you know, we're not standing for this, or let's have a meeting about it. Let's do some training. Let's change the curriculum, and then we can make a difference.
Yeah, I agree. Let's have a look at the chat. Jade has said, if everyone speaks up and out, that would create the cultural change needed within NHS, and we will save lives. Debbie Field-Pellew has said, how can doulas and midwives work towards having better professional relationships that are birthing mum focused? I think for that question, it would be for midwives and doulas to have a better understanding of each other's roles and to communicate throughout the pregnancy, throughout delivery, about what is needed for the client and what the client wants during her delivery. And not having a superiority complex over the doula, because that's not helpful. Sorry if you can hear the weather. Hence the lighting change as well. So that's what I think. Do you guys have any thoughts on that?
I think also just remembering that the birthing person is the one that's in control here. Like, we need to remember that they're the experts, like midwives, doulas, hypnobirthing instructors, like everyone. Your professions are amazing, like we're all amazing, but the birthing person is the one that's the expert over their own body. So ultimately they are the ones that know when there's something wrong first. So they're the ones that need to be listened to as well. But I know doulas are amazing at doing that as well, and midwives too. But yeah, communication, like you said, is absolute key. Like, just work together to put that person in the center of it.
Mm-hmm. Exactly.
Yeah, I agree with that too. I think I've met some amazing doulas last year that got me into journaling and like I spoke to them online and stuff like that. And I think there's just amazing, like there's nothing really negative about it. We're all working together to help a family have the most amazing time, and therefore we shouldn't be fighting against each other. We shouldn't be fighting in between teams. The birth centre shouldn't be fighting against the delivery suite. The doula shouldn't be fighting against the midwife. We should all be working together because we're doing holistic care. It's individualized holistic care, and therefore we need to work together so we can stop these numbers from rising. Because if we don't do that and we don't work as a collective, then it's not going to work.
I agree. Sandra, who's one of my lovely peers on my course at LSBU, has said, do you think that it might be beneficial to maybe have a peer advocate rep they can speak to in their trusts if they don't feel confident in approaching a CPF, and their issue can be dealt with discreetly if they wish? I think that is definitely a good idea because, you know, sometimes I can't really, from my experience, both my CPFs have been lovely and have always listened to me. But I know that some CPFs don't have the same approach. So if you don't feel comfortable speaking to your CPF for whatever reason, I think introducing a rep to be the middleman would be a good idea. What do you guys think?
Yeah, I know from when I was studying, we had 2 course reps, and they had a really good relationship with the year tutor. So any problems we had, once those 2 people were established, we would go through them, and then they would have meetings with the year tutor, like to sort out any problems and stuff like that. And I don't know if it would be, well, I do know it would be helpful if one of those reps were Black or brown, because you know, so everyone can feel comfortable going with any issue to the peer rep, not just a academic issue or something like that. Because obviously I know if I didn't feel comfortable to speak to them directly and I wanted to go through the peer rep, there wouldn't be a mutual understanding of what I was going through. So that is definitely a good idea.
Yeah, definitely a good idea. And that's something that all universities and trusts should consider. I'm personally a course rep, so maybe that is something that needs to be explored more at LSBU. Let's have a look. Karima has said, personally, speaking up is easier said than done for me. I think mandatory advocate rep, like Sandra mentions, would be a great idea for us students and also for the Black and brown women in our care to take their concerns and complaints to. There is nothing more disheartening than speaking up to the wrong person, someone who maybe does hold unconscious bias and nothing be done. I agree. So yeah, mandatory training should be done for everyone, all staff members teaching midwifery degrees and working in maternity services. What do you guys think?
I think it is scary actually just speaking up, and I think in my first year just before COVID hit, there's no way I would speak up. I wouldn't say a word because I'm the first year. I'm trying to get my book signed. I'm trying to make, I'm trying to achieve stuff, and it's like you don't want to rock the boat.
Yeah.
Before I even came on the course, I used to work in. I've worked in libraries my whole life, and I worked in a healthcare library in a university. And when I started finding out about being a midwife, I knew about the culture of bullying. I knew about the 4 times, 5 times likely that Black women would die in childbirth. I knew about all of that before I started, and that drove me to want to get into it. But yeah, I think I knew I was getting into a difficult role, but I knew that if I'm not here, then and if we're all not here, then there's no differences and changes are going to be met. Because there's something to be said of when you go into a room and when a Black mother sees you walk in, and as a student, you can see that they light up. They're so happy to see you there because they're like, there's someone that I recognize, and I can vibe with them. I can talk with them. They will understand my issues. So there needs to be more of us, and we need to work together.
I agree. Jane has just written in the chat, I have done the harvest test in my break just now, and I'm ashamed to say I have unconscious bias towards white people. I don't want to take that into my practice. Any ideas of how I can work on this bias? So the test showed that she's biased towards white people.
I might have missed when you was talking about this test, but obviously get the gist. I mean, I don't think you should be ashamed. Like, everyone's learning here. There's a lot of books you can read. There's a lot of films you can watch. There are a lot of people you can follow on Instagram.
Yeah.
Again, I wasn't here for the start of the conference, but I'm sure you might have mentioned some people. I know Mars mentioned about all of her social media pages. It just starts with like research, and you need to get into that research and find out for yourself the information, the stats, what you can do, and this is the first step. So, you know, I'm sure at the end we can send you some links, people to follow and things to read.
Yeah, I agree. Let's have a look at the chat. Jade has suggested This Race is a System by Jane Elliott as a great starting point. So maybe we can all make a note of that and have a look into that. Thank you, Jade. Does anyone have any questions that they want to ask us directly? Any hands up? So I have a few things here that we can all do to educate ourselves, to understand the trials and tribulations and the trauma people of colour go through in regards to their health. So educate ourselves, go to seminars, read the literature. There's so much out there, podcasts, media, poetry. There's so many sources out there that can really educate you on what people have been through and how they feel. Do you guys have anything to add?
I know there's a few things that we spoke about last week, and I wrote a little list, like conversations. That's a great starter. Oh, I think someone's got their mic on. Name pronunciation, we spoke about that. It's so important, like when you're on placement, if you don't know how to say someone's name, just ask them. They would rather you ask how to pronounce their name than you say it wrong, or you call them thingy, or you refer to them as a bed number, or things like that. These are all things that I witnessed on placement, which are just like, they're just unacceptable. We also mentioned Mind the Gap, which is a clinical handbook which show different signs of symptoms of conditions on Black and brown skin, because they can look different than on white skin. That is a good place to start if you're preparing for placement and things like that. And then lastly, I know we mentioned lecturers. So obviously, I think a big change needs to happen there, and they need to choose their language carefully, and how they're presenting the lectures, what information they're giving out, and how they are supporting their Black and brown students. And I remember we also mentioned, this is probably a long way off, but implicating something in the interviews. So when you're going for an interview, perhaps there needs to be certain questions around race, around Black and brown women, you know, because you need to know who you're essentially employing to have out in this profession.
No, I agree. I think universities need to vet their applicants a bit more when it comes to race, and make sure they're asking the right questions. Jade is putting lots of good suggestions in the chat. Silence is Not an Option, a book by Stuart Lawrence. Does anyone else have any questions?
I just say another thing while you're waiting for a question. I also think people need to be more culturally aware, so that like have training and understand that there was an incident once, and I was working with my a supervisor, and when I went into the room, it was a Black mother, and she's from the same kind of background as me. So she was she instantly changed her dialogue. So, you know, like we have a way of speaking to each other. She changed her dialogue and spoke to me in like a bit of slang kind of like, and she changed the way she was talking. And then when I left the room with my supervisor, they turned around and said to me that why was she using infantile language? So things like that, I think people need to be fully aware. It's like I turned around and that basically said to her, it's the same as if you spoke French and you went into a room and the mother spoke French, you'd speak to her in that same way. And I think people need to be more aware that there is a way that we speak to each other, and we code switch. So my voice that you hear right now might not be the voice that I speak to my friends with. And need to be aware of that and not be ignorant of the fact that everyone speaks in different ways. Every language in the world has a slang or a way of talking to each other that we just get, and people need to be more aware of that, I think.
I agree. Jordan has suggested I Am Not Your Baby Mother by Candace Braithwaite. That's a good one. So if you have a question, this is the time to ask.
Following on from the point you just made, Renee, I think it's also about respect as well. Like birthing people will come in the hospital with different types of food. You might not know what that food is. You might not like the smell, but you just need to respect the fact that that is the food that she wants to eat. It's just like little things like that as well. And you might not know about someone's culture, but ask them questions. They would be happy to tell you what it is that they're eating. I remember I had some jerk chicken, rice and peas, and I had a dumpling, and I was eating it at lunch one day, and my manager was like, oh, why are you eating a donut with your food? And he was asking questions about it, and I loved it. Like, I loved telling him about my culture and what I was eating, and I loved to educate him. He didn't say it rudely. Like, inquisitivity isn't, you know, like arrogance and rudeness if you have a genuine like eager to learn. So just ask questions and just like respect everyone.
Yeah, I agree. Jade has kindly left her Instagram page at the Sullivans London, and she says, I'm always educating on race on my page, so she's definitely one to follow if you want to learn more. And Jasmine says, and you get that one colleague who says, what's that smell? Yes. That's true. Someone has suggested the book Medical Apartheid by Harriet A. Washington.
I know that Akala recently wrote a book. I can't remember the name. I haven't read it yet, but I know that's had amazing reviews.
Yeah, Akala is a good author, so everyone check him out. Open and honest conversations will change the world. Learning for change. There you go. That's an Akala one.
I think also like understanding other people's experiences, because when I speak to like Black and mixed race student midwives, our experience is always completely different from like the white people in my class, or from if I speak to anyone, it's always completely different. And because we're dealing with the racism on top of it all as well. And I think that if changes are not made, like I hear loads of people dropping out of courses and they're like, I can't do this, and then that means we're losing really amazing midwives. And that's really sad, because
but we want you to come back, Jordan. We want you to come back. Come to LSBU. You'll be fine.
That's not good, because we're needed, and it's like, so we need to work on this. It's a problem. We've got to retain the student midwives from the start. We know it's going to be a challenge, but why should we have to deal with all that extra stuff on top of it? It's a challenging course, but having to deal with racism every single day and not being believed and not hearing our voices and people not wanting to work in a group with you, and all these different things are constant. And that needs to be looked at as well, I think.
I agree. It is such a challenging course. It's so hard. And Renee's in her second year, so she really knows.
Oh, yes.
And when you add racism directly to yourself, or you're witnessing it to someone else, it just takes the intensity to a next level. And we all need to be supported as students to deal with this.
Yeah, and I just want to say, like, if you witness racism during placement, or even like at uni when you guys can see each other in real life, I don't know if that's happened yet, but speak up. And if you're not heard, speak up again. And if you're still not heard, speak up again. Like, don't just, for example, I'm still speaking up now, and I stepped off the course maybe like the beginning of April, or maybe the end of March. Like, you just can't, like, you can't give up, because then nothing's gonna happen. So like, it is emotionally draining, but
yeah, it is draining. And don't be disheartened, just keep going. Keep going.
Loads of self-care, retail therapy, face masks, talk to each other, journal.
Yeah, lots of self-care is needed.
Yeah.
Have a good support system, family, friends. Talk to them, lean on them. but also try and make some good friends within your cohort. I think that will be helpful. And really use your link lecturers, your CPFs, your course leads to report anything that you see that is just not okay. But yeah, I think we'll draw the conference to an end. It's a bit early, but I think we've covered a lot. And for all my fellow Black and Brown peers, please take some self-care, look after yourself. It's not easy or having these discussions, so definitely look after yourself. I want to thank all the speakers, Jade, Mars, Sarah, for taking part in this conference today and really educating everyone about the disparities and what we need to do to make change. I'd like to thank Priya and Jim from the South Bank SU. They have been so amazing in helping me put this together and so supportive. I really appreciate their help. Jordan and Renee, we've got a newfound friendship. Thank you for joining my panel and supporting me in this. I appreciate you guys. I'd also like to say a big thank you to my cohort lead, Priti Patel. She's been very supportive and encouraging this whole time. And I'm just very grateful that I personally have amazing lecturers at LSVU teaching me midwifery, and my CPFs, Chloe and Chantal. I can't fault them. I think they're amazing. So thank you everyone for joining us today and being willing to participate and sharing your experiences and what you think. It's been really great. I have some links to some reading that you can all look into in your own time. This is by Georgia May Webster. She's a trainee doctor, and she has kindly composed this list of decolonized reading around people of color and health. So this it's an extended list, so please go check her out on Instagram or Twitter and get the full extensive list and use it to educate yourselves in what people of color face in healthcare. Thank you everyone for joining.
Amber, I'm just going to leap in here. Sorry to everyone. I've been very silent all day because this just obviously isn't my area, but it's been absolutely unbelievably fascinating day, and that's for someone with absolutely no background in this. But what I just want to say is, I mean, I'm sure that everyone here and our lovely speakers and everything are already aware, but Amber has done an unbelievable amount of work on putting this conference together. It is genuinely astonishing. I mean, for all of us at the SU, you know, me and Jim basically just put the tech together, and Amber pretty much did everything else. Honestly, you've been a star, Amber. Thank you so much for organising this. And yeah, I just really wanted to make everyone aware of that. You know, if we were in like a real in-person conference, I'd probably be handing you like a bunch of flowers or something at this point. So, you know, just want everyone to kind of give Amber a huge I guess virtual round of applause, because she has really done an unbelievable amount of work for someone who's also holding down a degree in several jobs. So huge, and thank you so much for organising.
You're welcome. Thank you so much, Priya. So that concludes our session today. There will be a feedback form sent to your email, so if you could fill that out, we'd appreciate it. And this session is recorded and will be available on YouTube, so you can watch back or share with your peers or colleagues. Okay, thank you so much, everyone.
Thank you.
Thank you, thank you, thank you.
Thank you so much.
Thank you so much, Amba.
Thank you.
Thank you.
Yeah, thank you, Amber. I thought I'd chime in as well and make sure.
You're welcome.
Thank you.
Thank you so much. Bye.
Amber, Amber, are you still there?
I'm still here.
Do we get a certificate for this, Benny?
No, sorry, it's not a CPD thing.
It's not for any PD hours thing, right?
No, sorry.
It's all right. You've done well.
Thank you.